Hello, good evening, everyone, and it's a great pleasure to welcome you all for this current oncology update series 5. It's a 2 days program, and yesterday we had a brilliant discussion, and it's a pleasure to welcome the organizing team, Dr. Chaturbuj Agrawal sir, Dr. Rajat Bajaj, and Dr. Vankat. To start the proceeding, it's a great pleasure to welcome and invite Dr. Chaturbuj Agrawal, consultant medical oncologist at Bahrain Specialty Hospital, Bahrain. So, good evening, Dr. Chaturbuj. It's a pleasure to have you with us today. I give the floor to you for your welcome introduction and starting the proceedings, please. Over to you, sir.
So, good evening, everyone, and I welcome you all. So, I could see, yes, so many people have already joined. So, thanks once again, Tarun, for setting up such a nice flow. And we have seen most of the progress, whatever has happened in the last decade, is in lung cancer and breast cancer, particularly in lung cancer and non-small cell lung cancer. We have seen lot of new drugs coming in, immunotherapy popping in, lot of new drugs coming for EGFR positive lung cancer. Initially those drugs were approved initially for metastatic disease, but then these drugs started entering the armamentarium of stage 3 and localized stage also. So I must tell you that stage 3 lung cancer, it almost comprises almost 1/3 to 1/4 of all NSCLC patients, and it's a very heterogeneous group. And that's why we call it as locally advanced disease or loco-regional disease, because we don't know. For some surgeons, somebody will feel that it's a operable cancer, but at the same time, another surgeon may feel that it's an inoperable cancer. So it's a very heterogeneous group as far as disease stage and as far as inter-observer variability is concerned. And the two most important factor which basically decide the prognosis in lung cancer is the stage and the performance status of the patient. And second thing, with in the last few decades, we learned that the tumor molecularly and immunologically mediated tumor, so those markers, they further define the prognosis. So without much delay, we would start, and we would start in, so the flow today will be to cover, we try to cover all the updates in lung cancer. We would first start with stage 3, and then we will slowly move to metastatic disease, and we will see that how our thought process, the things has changed after ASCO 2021 and after the new abstracts which were presented in WCLC. So to welcome without much delay, I would like to start stage 3 EGFR positive lung cancer. We have seen that post-definitive chemoradiation, it is now not conventional chemotherapy all the time. And we started moving our thought process to either immunotherapy or targeted therapy. So post unresectable NSCLC, post-definitive chemoradiation, what to choose, durvalumab or osimertinib? And that is the topic of debate today. So we have two excellent debaters. I don't need to introduce them. Dr. Kunal Jain, my dear friend from Ludhiana, he will be speaking on durvalumab, and Dr. Rekha Bansal, she will be speaking on osimertinib. So I would like to invite Dr. Kunal. Dr. Kunal, yes, please. So the floor is open for you.
Yeah, thank you, Dr. Agrawal. Thank you so much for the kind introduction, and also to the team for inviting me for this meeting. So are the slides visible? That's the biggest challenge always.
Yes, sir. Yes, the slides are visible and you're audible, and you're also visible. Thank you.
Okay, so the topic that I'll be discussing over the next 8 to 10 minutes is EGFR positive stage 3 unresectable non-small cell lung cancer post chemoradiotherapy. So what do we do as a consolidation treatment? Do we do durvalumab, or is there anything else better than that, which we'll probably see in the next 10 minutes also? So I think I'll just begin with sharing this slide, which basically is trying to show that stage 3 lung cancer, as was just mentioned by Dr. Agrawal, is a very heterogeneous group, and there may be a lot of there is a lot of overlap and individual variability in terms of what you will be considering resectable and sometimes what is unresectable. So all three groups, A, B, and C, and maybe P3 and 1 usually may be considered resectable at most centers and in most circumstances, whereas other stages 3 of 3A, other parts of 3A and 3B are usually considered for chemoradiotherapy, and generally 3C is usually treated with more of systemic therapy considered more like stage 4. But yes, in some circumstances, you may be considering them for definitive therapy as well. So again, just showing the spectrum of disease that we can see with the stage 3 disease, A, B, and C, where 3 being involvement of usually the suprascapular nodes, supraclavicular nodes. So for stage 1, we know the current standard is surgery or SBRT in special circumstances. Stage 2 is surgery and adjuvant chemo, or if we have EGFR mutation from ADAURA trial, we know that 2 and 3 stages can be considered for osimertinib. But it is the stage 3 which is unresectable, although, okay, so those category of patients which are resectable can be offered surgery and then chemo followed by targeted therapy or targeted therapy alone. But in those which are unresectable, which will be the bulk of the patients of stage 3 of A or B, they are the candidates for concurrent chemoradiotherapy, provided they have good lung function and good performance status. And then what do we do after giving them chemoradiotherapy? So the current standard is consolidation immunotherapy. And stage 4, we all know that it is a systemic disease, so systemic treatment is the mainstay. For unresectable stage 3, the challenges are locoregional and systemic control. And from historical data, we know that concurrent chemoradiotherapy is now the standard of care for patients with the unresectable stage 3. Radiotherapy alone and sequential chemoradiotherapy are inferior to concurrent radiotherapy. But can we do better than concurrent chemoradiotherapy? Because even with this strategy, the 5-year survival rates are quite dismal, to the tune of about 15% or low. And multiple strategies which have been tested in the past, including incorporation of newer drugs other than what we use for chemoradiotherapy, induction and consolidation strategies, incorporation of targeted therapies like cetuximab or in geftinib in unselected patients in some studies, vaccine strategies and dose escalation, all of them have not shown to be of much benefit, which is kind of shown in this graph, that no phase 3 study of consolidation with chemo targeted therapy demonstrated a PFS or OS benefit in patients with unresectable locally advanced NSCLC. This we are talking till about 4-5 years back, till we got the definitive data from durvalumab. In fact, in this graph, if you can see, geftinib did do in fact worse as compared to the placebo. So the theoretical concept of some synergism between radiation and immunotherapy is because of thought process of control of micrometastatic disease, controlling distant failure and also local failure. Then increase in tumor immunogenicity because of radiation release of antigens, which may be promoting action of immunotherapy, and abscopal effect we all know from radiotherapy. So this brings us to the study in question, the Pacific trial, which was published in NEJM in 2018. And this was a phase 3 randomized double-blind placebo-controlled multi-center international study where stage 3 locally advanced unresectable non-small cell lung cancer patients who did not progress after definitive chemo-RT were randomized 2:1 fashion to either durvalumab every 2 weeks for 12 months or placebo. And PFS and OS were the co-primary endpoints. Everyone is aware of this data, which was presented at ASCO last year, where updated 5-year overall survival was superior in durvalumab arm. 43% patients were alive at 5 years, quite impressive, with a hazard of 0.72, 28% risk reduction. And updated PFS at 5 years, again, 33% of patients were alive as well, more than that, and they were also disease-free. So 1/3 of patients were free of cancer at that point of time. But what we need to understand from this study, which is the topic of our discussion, is the percentage of EGFR patients which were included in the study, which was the tested, which were conclusively positive, were only 6% in this trial, 43 absolute number of patients, and 67% were negative, whereas data for about 1/4 of patients was unknown. And what this study showed that irrespective of the predefined subgroups, every subgroup did show significant benefit. But when we come to EGFR status, those patients who were EGFR positive the magnitude of benefit was not that significant as compared to EGFR negative subgroup. So both in terms of PFS and more so for OS, it was not reported in the initial study, but in the subsequent updates, the forest plot shows that the hazard is just close to unity with wide confidence intervals for this small subset of population. So the 4 years update of this trial was published in JTO last year, and they did conclude that OS PFS benefit with durvalumab was observed across all pre-specified subgroups, with the exception of EGFR positive subgroup. But again, with a rider that because of the small number, any definite conclusions were not possible. We are always worried when we are giving chemotherapy with some of the immune-related side effects. And once patients have received radiotherapy and chemotherapy, the one main factor which is worrying is pneumonitis, which may be radiation-induced and more compounded by durvalumab. So initial reports did not show any significant worsening of grade 3-4 pneumonitis, but subsequent reports did mention about 5% increase in pneumonitis reported in durvalumab arm to the tune of about 12%. So the concerns using immunotherapy, obviously one is lack of efficacy, which we know from the metastatic setting also, that immunotherapy does not work that well in patients who are EGFR mutation positive. And the second concern, as I mentioned previously, is the potential of toxicity, not only with the compounded by radiation, but also with the subsequent use of TKIs like osimertinib, which also have inherent tendency for developing pneumonitis. So is there any other data other than Pacific? So I could gather some retrospective studies. One of this is from Stanford Cancer Institute, a very small subset of patients, 36 patients with unresectable stage 3 non-small cell lung cancer. And out of them, 14 had tumor mutations. Out of this, 11 were EGFR positive. And what they showed that patients who were EGFR wild type did better than patients who were EGFR mutant, despite getting durvalumab. So this is a separate subgroup, probably not responding that well to consolidation durvalumab. Some of the similar authors, similar group, but with a larger multi-institutional retrospective study, again published in JTO last year, and higher number of patients were there. 37 EGFR mutant patients were there. Out of them, only 13 got consolidation durvalumab post chemo RT, whereas 24 did not get due to some reason or the other. And the biggest reason was investigator was not convinced that durvalumab can be given. So what this is also showing that patients without durvalumab, the survival, the PFS was about 23 months, whereas patients who got durvalumab, the PFS was about 10 months. But interestingly, if we filter out those patients who were given something else other than durvalumab, mainly EGFR TKI, the survival is kind of similar, and initial maybe 12 months or so, durvalumab slightly doing better, but have to be taken with a pinch of salt because this is a very small population of patients, and we are kind of teasing out the data till it is saying something. So possibly just indicating that they are not worse than not giving anything. And this is the last study that I could gather. This is the group from Taiwan, where they had again got about 61 patients who were analyzed post chemo RT given durvalumab, and out of them 16 were EGFR mutation positive. And again, in this study, they showed that PFS was better in wild type EGFR as opposed to mutated, and time to distant metastasis and death again was similar, but overall survival was not significantly different as they showed in this study. So historically, there is dismal outcome for this category of patients with the reported 5-year survival of less than 15%. In my clinical practice, this is a very small subgroup of stage 3 non-small cell unresectable adeno-CA with EGFR mutation positive, and also more importantly in our setting, affordability, which determines what treatment we will be giving to a lot of our patients. And I feel that it is difficult to do separate dedicated trial in this subgroup. So till we have more data, this may be still considered the standard treatment option as durvalumab consolidation in all eligible patients with unresectable stage 3 NSCLC, irrespective of various factors, as from the Pacific trial. Retrospective studies, as I have shown, are not very encouraging for use of this strategy post-CCRT, and there are increased chances of immune-related adverse events, and some studies do show that if you start a TKI within 3 months of durvalumab, the incidence of pneumonitis and other side effects is more. So further data are awaited, and I think LAURA trial will probably clinch the treatment paradigm, or shift the treatment paradigm if it is a positive trial, and then we may be moving from immunotherapy to targeted therapy for this subgroup of patients. So the other question that I kept asking was, do I commonly test my stage 3 unresectable patients who are getting chemoradiotherapy upfront for EGFR mutation? Possibly not at this moment, but if it is going to make any change in treatment in future, possibly we will be testing these patients. Definitely for patients who are resected, we are testing because we have positive ADAURA data, but right now we don't have enough data. So again, when we are having such discussions Saturday evening, so what to do Monday morning when we see a similar patient, again will be a little bit of a dilemma. But I would say somebody who's fit and all comers, I would still be considering durvalumab unless there is a pressing contraindication to use this drug. Thank you very much. I hope we ended in time.
Yes, Dr. Kunal, thank you for a very comprehensive presentation, and I must say that you have finished it in time, and it was a difficult presentation because EGFR positive, what to do post definitive CTRT in EGFR positive is a difficult debate. So in in EGFR wild type it's a simple topic, but in EGFR positive it's a tricky one. So I think you already got the difficult topic, and now without wasting time, I would invite our second speaker, Dr. Rekha Bansal, to go with the flow for EGFR positive unresectable NSCLC post definitive CTRT. So over to you, Dr. Rekha.
Thank you. Good evening, everyone. I thank the organizers for this opportunity. And my colleague here has made my job really very easy. I'm sure now everyone's convinced that durvalumab definitely should not be used in EGFR positive patients because it has limited benefit, and it's coming, that little benefit is coming at a high expense of increased side effects. So let's go through the details. So I think the guiding principle that all of us abide by is that at least we do not want to do any harm when we treat our patients. And we always choose a treatment option weighing the risk and benefit ratio. So I understand this question remains unresolved, and it will remain unresolved for some time until we have the LAURA data. But we need to look into the critical aspects, and we need to know what we should not do. At least we should not give durvalumab to this set of patients. So let's go very quickly go through some facts. So incidence in stage 3 reported in different studies is around 10 to 30% of EGFR mutation being positive. I think in Asian population, this might be slightly more. Yes, I agree with my colleague that we are not testing, but I think we should start testing because only then we will have more and more data to really see whether durvalumab, and I think that was the mistake which Pacific made by not accruing only EGFR positive patients. Some other facts. Now, EGFR mutation is present when we compare that with a wild type NSCLC. Definitely, this is the driver mutation, and the biology of the disease is going to be different. So we cannot use the same treatment for these two different group of patients. And we have this meta-analysis which clearly shows that in EGFR positive patients, the immune checkpoint inhibitors do not work. In fact, chemotherapy fares better than immune checkpoint inhibitors, and there are various reasons why this happens. It's more or less a immune inert environment, microenvironment, where in tumors which are EGFR mutation positive, thereby rendering them poorly responsive to immune checkpoint inhibitors. Not only that, in fact, the presence of EGFR mutation itself confers a bad prognosis. So there is this retrospective data which shows that whenever there is EGFR mutation positive in the same set of patients, that is unresectable post-concurrent CTRT, EGFR mutation positive patients had shorter PFS, they had higher recurrences, higher distant metastasis, higher brain mets. So all in all, it's a pointer that it's a bad prognostic marker, and it cannot be treated in the same way as the patients without EGFR mutation positive. And that is the reason why we are having this debate. That is, one size cannot fit all. So let's imagine a case like my colleague said. What are you going to do Monday morning when you have a patient of NSCLC, unresectable stage 3, post-CTRT, and who has not progressed after completion, still preserved performance status? So of course, the standard of care is durvalumab, but we need to get better because now we know that durvalumab is probably more harmful. So what are our other options? Probably osimertinib, probably observation. Let's look at the data. So there's the SEER cancer registry analysis, which followed patients for more than 13 years. And they showed that from first 1 year survival of almost 60%, this is less than half at 3 years. So it is this window of opportunity, this 2 years, when we have to do something different to improve this survival rates. And that is why maintenance therapy cannot be given up. We need to give maintenance therapy. So our options are just durvalumab or osimertinib. So choice obviously depends upon efficacy and safety. So coming to talk about durvalumab. So Pacific trial did not stratify the patients according to EGFR, nor did they first of all did not even accrue the patient. And this forest plot clearly says that EGFR positive patients, it is not benefiting. And in this subset of unknown EGFR mutation positive, again, I think mostly it was comprised of EGFR mutation positive patients. So we might say that the data was not powered enough to look for the efficacy, but then it was not even powered enough to claim efficacy. So we cannot just rely on this 43 patients whom my colleague also quoted, just 6%, which is not real world. I'm sure in stage 3, we see higher EGFR mutation positivity. So in the words of the authors themselves, they say that the use is limited and it comes at a detriment of higher side effects. Not only that, we don't even know whether these EGFR positive patients had PD-L1 less than 1, because we see commonly that EGFR positive patients have PD-L1 less than 1, and maybe that is the reason why they're not responding to durvalumab. Coming to talk of the safety, all grade toxicity, all toxicities were obviously higher in the durvalumab arm. Pneumonitis, any grade was higher. Grade 3-4 was higher, and the discontinuity rate was also higher, 6.3%. This is the trial data. When we talk of the real world, this obviously the numbers are way higher. The discontinuity rate in Pacific R data is 16.7%. As if this was not enough, in Asians and EGFR positive patients, the reported pneumonitis is way higher. To add to this, so when there is data from TATON trial data and the retrospective analysis, which says that after using immunotherapy, if we were to give osimertinib, the pneumonitis levels are unacceptable. So we cannot subject our patients to this much of toxicity. And how will we give the only drug we have in stage 4, that is osimertinib, after progression? I mean, let's say you give a patient of EGFR mutation positive durvalumab, later on the patient may not even be in a position to take osimertinib. So all in all, consolidation durvalumab is causing more harm than benefit in this subset of patients. Now let's talk about osimertinib. There is this prospective randomized phase 2 trial data, which was conducted back as early as 2012. In 2012 itself, they were thinking of probably using EGFR TKI. So they used erlotinib with radiation, and erlotinib was used until progression in this subset, and they found that there was definitely a PFS benefit. And the adverse effect profile was not worse than the chemotherapy arm. Benefit was seen across all subgroups. So that was a prospective randomized phase 2 data. Now coming to talk of the retrospective data, which my friend also highlighted, this is retrospective for sure. But then you can see that the analysis is clear. So whether you give durvalumab or not, post CTRT, there's no difference. But if you give EGFR TKI, definitely the PFS is better. So much better that it was almost 26 months. And not only that, durvalumab arm came at a higher cost of severe immune-related adverse events. So when you see actually the breakdown of the adverse events in the EGFR positive patients, the pneumonitis was always high grade, requiring hospitalization and requiring steroids for stabilization. This is a separate analysis. And here they looked at both HER2 positivity and EGFR positivity. Irrespective of any mutation, probably these tumors do worse. Like, any oncogenic driver is present, that tumor is doing bad on durvalumab. There is some more pointer from ADAURA data. So in Adora data, as the stage increases, the response increases, the hazard ratios are better. Now, what does this mean? This probably means this osimertinib is actually for this locally advanced set of patients, and definitely it's going to be useful. So while we await LAURA data, I think my understanding of this is durvalumab questionable benefit and more adverse events. Osimertinib definitely effective and more safe. So though the data I've quoted has small sample sizes, mostly retrospective and not the standard of care, the whole point is to reinforce that there is a lack of benefit with the use of durvalumab, and it's not an effective treatment for this set of patients. There was another study which tried to look at the MRD, molecular residual disease, post chemoradiation in the terms of circulating tumor DNA. So when the circulating tumor DNA was looked in both EGFR positive and EGFR wild type patients, EGFR wild type patients with a MRD, they responded to immunotherapy, whereas EGFR mutant patients who had ctDNA, despite having ctDNA, they did not respond to immunotherapy. So ultimately, I don't think consolidation durvalumab should be administered to these patients who are stage 3 EGFR mutation positive post CTRT. Thank you. I rest my case.
Thank you, Dr. Rekha. Thank you for a nice presentation. So I think as far as I understand from both the speakers that we are clear that in EGFR mutant NSCLC, we should not be using durvalumab in the consolidation phase. And this is as per my understanding also, because we all know that the biological mechanisms underlying, the immune inert phenotype of EGFR mutant NSCLC, it remains, it is basically incompletely understood. But within the tumor microenvironment, if we see tumors, they harbor EGFR mutation, they were found to have lower levels of EGFR, lower levels of PD-L1 mRNA and protein expression. Second thing is in considering, if you consider the Pacific regimen as rightly shown by Dr. Kunal, that durvalumab was administered as a consolidation therapy with the hope of exploiting the immunogenic environment that resulted from radiation-induced tumor cell destruction, which is not at all there in EGFR positive, EGFR mutation positive subset. So these are the possible pathophysiologic mechanisms that why we don't tend to use immunotherapy in patients who have got unknown driver mutations. So I would just quickly answer Dr. Kunal's questions that are we still testing EGFR mutation upfront in stage 3 NSCLC? So yes, we do test all the time whenever we get a chance to diagnose NSCLC, even in stage 3, we do test. So if somebody differs from me, so I think he can tell. Otherwise, I think now it's a standard practice guideline that we are doing it even in stage 3. Do you agree, Dr. Rekha? We are testing in all the patients of stage 3 NSCLC?
Yes, so whenever we have tissue, any data adds value to the information. So I think we should encourage more and more testing at all stages.
So that is one thing. And second thing, what we do Monday morning. So I think the answer is clear. The only question which I wanted to ask, your thought process is, if some patient by any chance, if you landed up, so I'm telling you a hypothetical scenario. There is a EGFR mutation positive NSCLC patient, stage 3, who has completed, chemo radiation. And due to some concerns, you cannot give osimertinib. So what will you do? It's a EGFR mutation positive stage 3 NSCLC post chemo radiation. So not osimertinib not available. So will you put him on observation or durvalumab?
Durvalumab, sir. At least something is better than, because we cannot not give anything.
So at the start of presentation, you said at least don't do any harm if you're not doing anything good.
No, so is it a standard practice, right? I think we'll not be having this debate next year probably anyway if we have other data. But till the time we have that, are we using osimertinib as standard treatment post CTRT for EGFR mutation positive patients right now? We don't have that approval.
Yes, we don't have data.
We don't have, yeah, exactly. So we cannot go against the standard of care.
So anyway, I think the floor is open for questions, if any. Otherwise, we have excellent debate. I must not say this was a debate because both the debaters were actually debating on from the same side. So anyway, thanks a lot to the speakers. And I must say that whatever we do Monday morning, whoever we follow, Dr. Kunal or Dr. Rekha, and whether we give durvalumab or osimertinib, the winner will be AstraZeneca. So our next session is sponsored by AstraZeneca, and for that I would like to invite Dr. Ankit. So Dr. Ankit, over to you,
Hello.
please.
Good evening, everyone. Am I audible?
Yes, you're audible, Dr. Ankit, but you're
And
not
my
visible.
is my screen visible?
Your screen is visible, but we want to see you also. You are not visible.
Just 1 second, sir.
No issues, Dr. Ankit. You can start, no problem.
Am I visible now, sir?
No, not visible.
Okay. Anyway, without wasting further time,
Yes.
I would like to thank the organizer and AstraZeneca for giving me this opportunity. So I'll be talking about new practices in the management of early stage lung cancer. So managing early case lung cancers, like for example, we have a female, 46 years old. She came with the suspicious mass on a chest X-ray and a CT scan was done, which showed a speculated 4 centimeter nodule, and biopsy was done, which is non-small cell lung cancer, PTF1 positive, stage 2B, with the EGFR on biopsy showing exon 19 deletion, and surgery is planned. So whenever we see these kind of cases, we have some questions to ask, like what are the chances that the patient will not recur after surgery? What would be the expected 5-year overall survival, or can the patient expect cure? And can the survival be increased beyond historical data? And we know the driver, should be targeted, why and how? So before answering this question, I'll just take you through some data. If we talk about lung cancer, only about 13 to 17% of the lung cancers are localized and in early stage. And unluckily, we have around 50% of the patient in advanced stages. So approximately 25% of the patients with non-small cell lung cancers are diagnosed in a resectable stage and are taken through surgery. So if we talk about the 5-year overall survival, the 5-year overall survival of stage 1 itself is very heterogeneous and ranges from 77 to 92%, whereas in stage 2, it is around 50 to 60%. And it decreases as on the stage increases. So after the initial treatment, more than half of the patient, like 50 to 60% after surgery and adjuvant treatment recur. Either they recur locally or distant. So given that more than half of the patient recur after the curative intent surgery with the adjuvant treatment, there is definitely an unmet need to improve the neoadjuvant and the adjuvant treatment in order to improve the outcomes. So adjuvant chemotherapy is one option, and after surgery, it is given for most of the patients for stage 1B to 3A non-small cell lung cancer. And overall, it gives a DFS benefit of 5% over 5 years and no overall survival benefit. So there are basically 4 major trials: the JBR trial, CalGB trial, ANITA trial, and ILT trial. So in ANITA trial, we can see that there is slight overall survival benefit and DFS benefit. Whereas in the LACE meta-analysis, there is only 5% DFS benefit and doubtful ONS benefit. So with the adjuvant chemotherapy, we don't see any OS benefit. And ASCO also recommends adjuvant chemotherapy for stage 2A, 2B, and 3A, and not for stage 1B. Whereas NCCN recommends for stage 2A to 3A, and only for high-risk patients with stage 1B. Now, what other options? Other options are like EGFR TK in the adjuvant setting with EGFR positive non-small cell lung cancer. We have various studies till date, like the SELECT trial, which had included stage 1 to stage 3 EGFR muted, gave erlotinib after adjuvant chemotherapy in RT, and had only been shown that as compared to the historical data, around 12% improvement in 2-year DFS, but no OS benefit. Then the RADIANT study also gave erlotinib, but it has placebo to compare with, and it showed that clinically meaningful DFS improvement was seen in terms of 28 versus 46 months, but no OS benefit here also. Then EVAN study stage 3A, they have not taken stage 1 and stage 2 EGFR muted, and they have compared adjuvant erlotinib versus adjuvant chemotherapy, and DFS improvement was seen as compared to the previous studies. Then CTOM 1104 study, they have given gefitinib versus adjuvant chemotherapy in stage 2 and 3A EGFR mutant post surgery, And there was a DFS improvement 18 versus 28 months, but no significant OS improvement. And similarly, the VR study. So overall, we have DFS improvement, but not translated into a OS benefit and not translated into an approval also to change the clinical practice in the adjuvant setting. So what next? So then there is ADAURA trial. So ADAURA trial was presented with the interim analysis in the late 2020s and also in the ASCO 2020 in the plenary session. So adjuvant osimertinib versus placebo in completely resected EGFR mutant stage 1B to stage 3A non-small cell lung cancer. So the merits of the trial is a phase 3 double-blinded randomized placebo-controlled trial to assess the efficacy and the safety of osimertinib versus placebo in patients with completely resected EGFR mutant stage 1B to 3A non-small cell lung cancer. So it included Asian patients from Japan and Taiwan who are above 20 years, good PS, non-squamous, non-small, and EGFR mutation in terms of exon 19 deletion and L858R mutation. So they have stratified by 4 things like stage, EGFR mutation, and race. And the patient received either osimertinib, 80 mg OD, or placebo. So the baseline characters were well matched in terms of sex, age, smoking status, race, whether Asian or non-Asian, PS, brain imaging, staging and histology, and EGFR mutation, as well as adjuvant chemotherapy, whether it was given or not. So when we look at the primary endpoint was DFS in primary population, that is stage 2 and stage 3. We see a significant difference between the graphs, and it started separated early. And there was a Haddad ratio of 0.17, which we have never seen before or heard before in oncology. So the median DFS was not reached till the time the study was reported in the osimertinib arm, whereas it was 19.6 in the placebo arm. Similarly, the secondary DFS, the secondary endpoint, that is the DFS in the overall population, was also strikingly different, but the hazard ratio was slightly less and is was 0.2. So ADAURA has shown a 2-year DFS which was consistent for the osimertinib arm across the disease stages, like from stage 1B, 2, and 3A, and it was highest in stage 3, which was showing a hazard ratio of 0.12, which is the highest risk and likely to be expected to be like relapse early. So when we see at the subgroup analysis of this disease recurrence or the death, it has shown benefit in all the categories, irrespective of sex, age, smoking history, race, stage, EGFR mutation, and adjuvant chemotherapy. So it has benefit in all the subgroup analysis that osimertinib has shown to be better as compared to placebo. When we talk about the stage and chemotherapy used, at least 60% of the patient has received chemotherapy, and the maximum was seen in higher stages, like stage 3 has received the highest 80% as compared to stage 2, which was 17, and stage 1B has received like only 26%. So the outcomes in this patient who have received adjuvant chemotherapy or not, it was also compared in a subgroup, and DFS benefit was observed across both the groups, irrespective of the chemotherapy was given or not. But we can see between both the groups that even with chemotherapy or without chemotherapy, in the osimertinib arm, the 2 years DFS was 89% as compared to 49 in patients with chemotherapy versus 58 without chemotherapy. So osimertinib has not interfered with the benefit. Chemotherapy has not interfered in the benefit of osimertinib. So ADAURA, the type of recurrence is the key concentration. We have thought like if the patient recurs, and then what to give. So the benefit is that once the patient has recurred, it is very difficult to salvage if it is a distant metastasis, especially CNS. But we have seen that in this cases, the CNS is the most common site which has benefited. And osimertinib has been shown to achieve clinically significant exposure in the brain compared to other TKs which were used in previous trials, and has greater penetration in the blood-brain barrier. So in an advanced test setting, the first line osimertinib has demonstrated a superior overall survival and a 52% reduction in the CNS progression as compared to erlotinib and gefitinib. So in this particular trial, 11% patient in the osimertinib arm has a DFS event, and versus 46% in the placebo arms. Out of these 11%, only 38% have recurrence in the distant recurrence in the CNS, whereas in the placebo arms of the 46, 61% has distant recurrence. So the site of distant recurrence, as we talked, that in CNS, it is 1:10, 1% in osimertinib arm, whereas 10% in the placebo arm. And most of the recurrences were in local or regional lymph nodes or like lung region. And distance recurrences were very less in the osimertinib arm as compared to the placebo. Similarly, this 3 years DFS in the CNS in overpopulation, there was a striking 16% difference. And the median CNS DFS was not reached in the osimertinib arm when the study was published as compared to placebo, which was 48%, 48 months. In terms of safety, no new signals or no new side effects was observed in the adjuvant setting, and no death related to adverse effect has been seen in the osimertinib arm. There were mild to moderate interstitial lung disease, but which required discontinuation and dose reduction in few patients as compared to placebo. So coming back to our case, if we answer those questions, like after surgery, only 53% patients had 5-year survival in stage 2B. Hence, there is a clear need to improve. There is a chance for improvement for better outcomes. And yes, when we know that driver mutation in early stage, we should target that driver mutation. And definite scope of improvement in DFS with the use of adjuvant osimertinib has been seen in ADAURA trial with a 2-year DFS of 91% and 83% risk reduction in stage 2. So the 5 key takeaway points from my side will be to identify in order to improve survival. We need to put more efforts to identify the lung cancer early, to test, as we were discussing previously in the previous session, never miss an opportunity to test for actionable mutation. Now this applies to early lung cancer, especially for EGFR. And to collaborate with multidisciplinary team is the key to improve survival. And to discuss, patient may ask for treatment options for best survival probability, and we should be ready to discuss these options after definitive treatment with the aim to cure. And ADAURA trial definitely gives the data to probability of the patient to remain cancer free. Thank you. Any questions?
Yeah, thank you, Dr. Ankit. So thanks for the very crisp presentation. So you might also agree that how these drugs. So I think in oncology, this is a usual thing that the drugs will initially get approved in the metastatic setting, and slowly, then they will move towards the early stages, and there they get approval. So same is the case with this anti-EGFR drugs also. So I would like to ask you one question. So what is in your clinical practice? Do you offer osimertinib to all early stage lung cancer EGFR positive, whether they underwent surgery or post chemo radiation? Means I know LAURA data is awaited, and we already had a good discussion by Dr. Kunal. So what do you say?
So basically, since we have a DFS benefit only and no OS benefit, I will definitely discuss with my patient and take an informed decision along with them. I will not push for that, and take a joint decision with the patients.
Okay.
And definitely, like in my clinical practice, like 20% of the patient are accepting that treatment.
And what do you do post? So stage 3 NSCLC is a very heterogeneous group. We discussed it all, that patient could be operable, it could be inoperable. So it also varies as per the institute. It also varies as per the surgeon. That some surgeon may feel that it's operable, some surgeons they feel it's inoperable, and even the chances of there is a very blurring of margin between discrete N2 and incident, discrete N2 and incidental N2. So sometimes people feel that it should be surgically excised as far as possible, and some I have seen many people that who are very much surgical pro. They wanted to do surgery for most of the cases. So what do you think if the patient has underwent surgery and if is EGFR wild type? What is your clinical practice? Means what do you offer standard adjuvant therapy?
Sir, if it is EGFR wild type, then we offer 4 to 6 cycles, mostly 4 cycles of cisplatin-based chemotherapy.
Okay. And do you check for PDL1 upfront?
So we discuss with patient. If the patient is affordable for the treatment, then only we are going to check. And otherwise, we are not checking routinely.
And what treatment you are going to offer? I'm not talking of patients who underwent chemo radiation. I'm talking of patients who underwent surgery.
Yes, sir. After surgery, like if it is like margin or N2 disease, then adjuvant RT. Otherwise, adjuvant chemotherapy 4 cycles, cisplatin based.
Okay, I think we are running short of time. I can see in the chat box. So without wasting time, thanks, Dr. Ankit. Thanks a lot for your comprehensive presentation. And now it's time. Yeah, thank you. So now I think it's the time to see that whether all EGFR mutation are same or different. And for this, we have a next talk on dissecting molecular differences between exon 19 and exon 21, which are the most two common mutations that we encounter. And for this, I would like to invite my dear friend, Dr. Nagendra Sharma. He doesn't need an introduction now. So he's from Department of Medical Oncology, Consultant Medical Oncology at Medanta Cancer Institute. So over to you, Dr. Nagendra.
Thank you. Thank you very much, Dr. Chaturbuj. And thanks, thanks for the organizing team for giving me the opportunity, and especially Pfizer for giving me the opportunity to present this topic. So the most common question which is asked these days in webinars is whether my voice is audible and whether my slides are visible. So can somebody from organizing team can answer this question?
Yes, your slides are visible, you are audible, you are visible.
Thank you. Thank you very much. So we are good to go, and we'll start. I'll come straight to the point. So the topic for today's presentation is dissecting molecular differences between EGFR exon 19 deletion and exon 21 L858R mutation. This is the hottest topic right now, and how evolution of lung cancer have occurred over the last 1 decade. We have seen that NSCLC was once considered a single disease until distinct subtypes or characteristics were identified. NSCLC subtypes characteristics are clinically relevant for treatment planning from diagnosis itself. So it started with only differentiate between NSCLC and small cell lung cancer, and over a period of time, we came to know that they are divided into so many molecular subtypes like EGFR, ALK, ROS1, and the list is expanding exponentially. Now we are looking into PD-L1 expression, whether it's less than 1, greater than equal to 50%, less than 49, like 1 to 49%, tumor mutation burden, less than 10 mutation per megabase, or greater than equal to 10 mutations per megabase. So, and now also we are moving forward for it. So focus for today's presentation is EGFR mutation, and EGFR gene, just a brief touch, that is epidermal growth factor receptor EGFR, ERB1, that is HER1 in humans, is a member of ERB family of receptors, that ERB1, HER2 or ERB2, then HER3 and HER4. This is what it is. Now, EGFR mutations are basically activating mutations, and there are 4 things which you have to remember. That there is a ligand binding, there is a transmembrane, there is a tyrosine kinase domain, and a autophosphorylation. So in the tyrosine kinase domain, basically we are having all these exons, exon 18, exon 19, 20, 21, 22, 23, 24, and this are subdivided into the deletions, mutations, insertions, all these things are there. So nearly the focus is that majority of them, they are deletion 19 or exon 19 mutation, and L858R, that is on exon 21. So focus of presentation is that because majority of the mutations are in these 2 mutations only. Rest all are uncommon mutations. So EGFR mutations are seen in subset of NSCLC patients and represent an effective target for TKI therapy. Responses to anti-EGFR TKI therapy is superior to standard platinum-based chemotherapy. EGFR testing and anti-EGFR therapy is standard of care in patients with advanced EGFR positive NSCLC. As we all know, 93% of EGFR mutations are present in exon 18 to exon 21 of the gene encoding the tyrosine kinase domain. The mutations in exon 18, 19, 21 are predictive of sensitivity and are considered mutations in exon 20 are predictive of resistance. Deletion 19 and L858R accounts for 44.8% and 39.8% of EGFR mutations respectively, and both are predictive of sensitivity to EGFR TKI therapies. Right? So we can remember like 45% of the patient will be having deletion 19, and around 40% of patients will be having L858R. This is what the focus of presentation is today. So first generation, second generation, third generation, the PKIs in EGFR they are not equal. So we are having plethora of options right now, but they are not equal. Their activity are different. So initially started with erlotinib and geftotinib, which were first line TKI, which were reversible binding to wild type of or mutant EGFR domain. Then it was inactive for T790 mutant. Then came the second generation TKI, which are afatinib and dacomatinib. There is an irreversible covalent binding to EGFR and ERB2, ERBB4 to inhibit all ERBB family of signaling. And there is a broader activity to overcome the EGFR TKI resistant division. And later on, we came to know that osimertinib, which is third generation TKI, it is specifically to EGFR T790 mutation. It targets specifically to this EGFR wild type sparing is there, and irreversibly covalent binding to mutant EGFR is present with osimertinib. That's why I say third generation. molecular differences of EGFR mutation subtypes. So there is a high frequency of compound mutation with L858R mutant tumors. The compound mutations are seen in 19.5% of L858R mutated tumor as compared to 4.7% of deletion 19 in 390 specimens of L858R and deletion 19 EGFR mutant NSCLC. So this is very, very important because it is very, very tough to treat these compound mutations. So they are more commonly seen. They are nearly 4 to 5 times more commonly seen in L858R as compared to deletion 19. L858R mutation incidence of concomitant mutations and clinical outcomes also was assessed in a retrospective cohort study in China between 2012 to 2014, in which 58 cases were taken of EGFR mutant advanced NSCLC and cell-free DNA obtained before treatment and was subjected to NGS in 49 cancer-related genes. And what they have found out that 69% of the patients of L858R, they are having O mutations as compared to 41% of the patients who are having deletion 19. And the PFS, median PFS, was 18.77 months as compared to 6.2 months in those patients who are having concomitant mutations not detected versus concomitant mutations which were detected. And overall survival, median overall survival was not reached in those patients who are having absence of concomitant mutations as compared to 22.7 months only in those patients who are having concomitant mutations. Tumor mutation burden in tumors with deletion 19 is significantly lower compared to tumors with L858R mutation despite similar smoking history. Concomitant TP53 mutations are more common in patients with high TMB compared with lower intermediate TMB. The TMB is negatively associated with clinical outcomes in metastatic patients with EGFR mutant lung cancer treated with EGFR TKIs as depicted in this graph. Now comes to deletion 19 L858R mutation associated with a different mechanism of resistance to EGFR TKIs. So in this retrospective analysis of 224 consecutively patients which were detected in advanced NSCLC patients, and the percentage of each resistance mechanism were detected in both deletion 19 and L858R subgroups. And what they have found out that prevalence of T790M mutation was significantly higher in patients with deletion 19 mutation as compared to L858R mutation, and there is a drug for that, we all know. And prevalence for uncommon mechanism was higher in tumors with L858R mutations compared with deletion 19, and p-value was 0.032, that was statistically significant. As compared to the inhibitory concentration, that inhibitory concentration at 50, the nanomole values for dacomatinib, which is a second generation EGFR TKI, for exon 19 deletion and exon 21 L858R substitution are not very different, with IC50 values among lower for dacomatinib compared to other EGFR TKI for L858R mutation. As you can see, it is 2.6 for dacomatinib, for osimertinib it is 9, afatinib it is 4, and erlotinib 16, and highest for gefitinib that is 26, right? In the exon 19 deletion and exon 21 L858R, so pre-treatment T790 mutation more common with L858R as compared to deletion 19. Acquired mutations of T790 mutation were more common in deletion 19 compared to L858R mutation. Sensitivity to TKI, data says that deletion 19 might be more sensitive to EGFR TKI than L858R, and concomitant mutations. L858R mutation tumor have significantly higher incidence of concomitant mutations. So clinical outcome, how it is important for all of us as far as clinical practice is concerned. The clinical outcome differences of EGFR mutation subtypes. This is a very, very important slide, which all of us have to remember, that the proportion of patients who are having L858R exon 21 deletion, that is 40 to 45%, and deletion 19 is 45%. The clinical characteristics is the majority of patients of L858R mutation, they are older, they are more common on the right side of the lung, they are having lipidic growth is more commonly seen, and lymph node metastasis is uncommon as compared to deletion 19, in which the majority of patients are younger, they are more common on the left side, papillary type is more common, and lymph node metastasis is very commonly seen. The prognosis, by and large, we all know that L858R mutation carries poor or dismal prognosis. Deletion 19 carries a better prognosis. Malignant proliferation is higher, it is 32.6% in L858R, and it is 26.6% with deletion 19. And frequency of other mutations is 69% with L858R, and it's only 41% with deletion 19. T790 mutations rate after resistance to second generation TKI, it is 36 to 38% with L858R, and it is 53 to 63% in deletion 19. And sensitivity to Other EGFR TK is low with L858R and it's higher for deletion 19. So deletion 19 and 21 L858R mutations have different biological characteristics, clinical features, and prognosis, as well as different sensitivity to EGFR TKI. Therefore, there is a need to subdivide EGFR mutations, and the individual treatment for EGFR subtypes will be a key issue in future and now also. A higher proportion of T790 M resistant mutations may be contributing to the better survival in patients with deletion 19. This is by and large we all know. And as you can see, there is a deletion 19 deletions has higher sensitivity EGFR TKI compared to L858R. Higher doses are required to improve the median PFS and objective response rate in L858R. As you can see clearly, the regular dose and higher doses were used, and they have found out that those patients who are carrying L858R, they require higher dose to achieve the same quantum of benefit. Archer 1050, which is a landmark trial for EGFR mutation subgroup analysis, was done for dacomatinib, and the safety and efficacy of first-line dacomatinib in advanced NSCLC lung cancer with EGFR mutation subtypes in Archer 1050 was presented in 2020 in World Conference of Lung Cancer in Singapore, and median PFS was found for exon 19 deletion. It was 16.5 months as compared to definitive, it was 9.2 months, and hazard ratio was statistically significant. It was 0.55. For L858R, it is found out that the median PFS was lower, that is 12.3 months, and hazard ratio was 0.63. This was favoring dacomatinib. So both deletion 19 and L858R, dacomatinib is a drug which is working for both. Objective response rate and duration response by EGFR mutation subtypes. As you can see, the CR, the partial response, the objective response rates were better for those patients who are on exon 19 deletion. The median PFS also was 15.6 months, and hazard ratio was 0.454. Dacomatinib also it is showing better median PFS, that is 13.7 months. Same holds good, and we subdivide, and the subsequent systemic therapies with EGFR mutation also were better. We are using pemetrexed, osimertinib. We can use cisplatin, carboplatin, docetaxel. All these agents were used. Archer 1050 survival data for dacomatinib versus geftinib was compared, and they have found out that the leverage of dacomatinib was 5.9 months. So overall survival, if you see for deletion 19 patient, 36.7 months, vis-a-vis geftinib, if you see it is 30.8 months. Kaplan-Meier curve are wide apart. So there is a leverage as far as median PFS is concerned, and as far as overall survival also, it is better for dacomatinib. So in patient with deletion 19, dacomatinib significantly prolonged PFS compared with geftinib, and dacomatinib prolonged OS by 5.9 months compared to geftinib. Archer 1050, the survival of dacomatinib versus geftinib in patient with exon 21 L858R, the leverage was 9.3 months, right? So in patient with exon 21 L858R mutation, dacomatinib significantly prolonged PFS compared with geftinib, and dacomatinib prolonged OS by 9.3 months compared to geftinib. Obviously, this is a godfather for L858R, isn't it? So updated overall survival for dose-reduced patient treated with dacomatinib versus geftinib treated patients in L858R mutations and deletion 19 EGFR mutation subgroup. As you can see, the Kaplan-Meier curves are wide apart. So both the patients, the overall survival was better. As we compare the osimertinib data and the FLORA and compared with dacomatinib, as you can see, the FLORA data of L858R specifically, if you see, the hazard ratio was 1. The curves, the Kaplan-Meier curves are collinear, they are overlapping, and mortality distribution was 0%. As we can see for dacomatinib, L858R mutation, all the dots are on the right side of unity, favoring L858R mutation dacomatinib role, and it is much better even in those patients who are who have been exposed to dacomatinib. For osimertinib, the line of unity, the dots are touching a line of unity, especially for L858R. So survival with first generation TKI in patients.
Dr. Nagendra sir, apologies to interrupt, but you need to conclude, sir.
I will be just coming to the last slides. So dacomatinib was compared in Lung Cancer Summit Forum consensus also, and which is higher priority recommendation for exon 21 mutations. So in summary, I just want to summarize in a nutshell that based on the molecular and clinical data, exon 19 deletion and exon 21 L858R mutations should be considered as two distinctive types of EGFR mutation. Different EGFR TKIs have different role of exon 19 deletion and exon 21 L858R mutations. Exon 21 L858R is difficult to treat mutation. First line treatment with dacomatinib associated with prolonged PFS and overall survival in patients with exon 21 L858R mutation, as well as in those with exon 19 deletion. And last, the words of wisdom are that if we were not for greater variability among individuals, medicine might as well be a science, not an art, right? And he who studies medicine without books sails an uncharted sea, but he who studies medicine or medical oncology without patient doesn't go to sea at all. Thank you very much. And the last thing that I want to quote is multidisciplinary tumor board is very, very important. And if you want to walk fast, walk alone. And if you want to walk far, walk together. Thank you. Thank you very much for the opportunity. Over to organizers, please.
Yeah, so Dr. Nagendra, thank you.
Thank you. Thank you, Dr. Chadha.
Thank you, Dr. Nagendra. So it was really indeed a very good extensive presentation, I must say. So I would like to ask you one simple question. In the paucity of time, the floor is open for questions. So if there are any questions, please put it in the chat box. And I would like to ask you one simple question. As far as adjuvant therapy is concerned, like prescribing osimertinib as per ADAURA trial data. So how do you see both this subset as a different subset, or because we clearly know that presence of EGFR mutation itself is a poor prognostic factor. I'm not talking of predictor; it's a poor prognostic factor. So in presence of EGFR del 19 versus EGFR exon 21 mutation, how do you see both these mutations as far as prescribing these drugs post surgical resection? Means I'm trying to explore ADAURA data. How do you see these two mutations?
Your question is very, very pertinent, Dr. Chadha. Even I also think about that. But we know that the science is evolving right now. We know that ADAURA data is there, but we are not having an oral survival benefit. Obviously, L858R mutation is there, which carries a poor prognosis as compared to mutation 19. So, the patient in adjuvant setting, if you are having EGFR mutation and if you are having L858R, obviously we know that this patient is not going to do well. Over a period of time, it is going to come back with the disease in advanced state earlier than the patient who is having EGFR deletion 19. But as of now, it is very, very difficult to answer this question. Science is unfolding. In next couple of years, I think we'll be able to tell that, because oral survival is not yet there. Yes, the data is very much amazing, and we are all looking for that. We are doing EGFR mutation upfront in those patients who are having early stage cancer, who got surgery upfront, and we are searching, and we are always opening up this discussion with our family of the attendants, and if they are able to afford this for a longer duration, if it is financially sustainable, we are giving this TKIs. But as of now, it is very, very difficult to answer that which TKI we should offer. We should offer decomatinib in L858R in adjuvant setting, or we should offer osimertinib, no matter whether it's L858R or deletion 19. It is very, very difficult because there is no scientific evidence to back it up as of now.
And one quick question, which is a very common question, is, all the time in scientific discussion, we keep on talking that we are here to discuss science and not cost. But what I feel is we should keep cost into consideration whenever we discuss something, because ultimately, in whatever country you live, cost is always, even means, since the time I came to Bahrain, initially I thought cost will not be an issue, but no, here is also cost is an issue. Because cost discussion, I think it always comes to the front line whenever we discuss some treatment option. So my one quick question, which you may not feel very scientific. So a patient, Monday morning, a patient walking to you, EGFR del 19 mutation positive post surgical resection comes to you and he says, I couldn't afford osimertinib. Do you, at any point of time, do you consider any first generation TKI in adjuvant setting? So I already told you this might seem very non-scientific, but the patient can always ask you.
Right. Absolutely right. This is a very, very important point. It's not a wrong question, sir. It's a very, very important question you are asking. But as of now, as far as scientific data is concerned, we should practice based on evidence. We always tell that there is no evidence for first generation TKI in adjuvant setting. Osimertinib also is evidence is there, but overall survival is not there. If the family can understand, if they are having a logical mind, if they can understand that, the quantum of benefit also we should tell them. And financial cost, treatment is not a treatment until it is affordable and accessible to the masses, isn't it? So osimertinib, majority of times, not only in India, across the globe, it's not financially sustainable over a period of time. First generation TKI, right now, data is not mature enough whether we can use it. So I never offer them first generation TKIs. We always tell them, if you can afford, and if you understand the biology of the science, how it's unfolding, you should go for osimertinib. Having said that, I will always tell them it's not oral solid data is not yet there. If they can afford that, okay. If they cannot, I will go for adjuvant chemotherapy. and I will tell them this is the quantum of benefit. Major times we know that adjuvant chemotherapy is having approximately 5 to 10% of advantage. We always document that and we'll move forward.
So either purchase Mercedes or go walking. Okay, there is no chance of any Honda or Maruti, right? Okay, anyway, thanks. And I think next is we have an excellent panel discussion and I am a part of it. So I think Dr. Rajat, we all know him. He's a very good friend and consultant medical oncologist at Dharamshila Narayana Hospital. So over to him, Dr. Rajat.
Thank you, Dr. Chaturbhuj. So I have, I think, all my panelists with me, right? So Dr. Chaturbhuj is there, Dr. Novak is there, Dr. Kshitij is there, and Dr. Amit is there. So I think all are there, right?
Yes, all are here.
Yes, sir.
So I'll keep my discussion more practical. I think we have discussed a lot about the molecular heterogeneity of EGFR mutation cancer. So I'll try to ask more practical questions, and most of these questions are repeated in almost all the sessions that we are having. So I'll ask the question to Dr. Chaturbhuj only. So in what lung cancer patients you don't opt for an MRI brain? For the stage 4 lung cancer patients, you don't offer an MRI brain. So is that any subset of these patients that you don't offer an MRI brain?
So I think there is practically no other subset of patient. There is no subset of patient where I would not do an MRI brain, because if I don't do, patient will go to you and you will do. So better is I will do MRI brain.
So for all practical purposes, do you think that if you have a patient who is EGFR positive and who is not having any symptomatic brain mets, or who is not having any symptoms, so would you still like to offer, the patient is saying, Doctor Saab, chhod do na, koi baat nahi?
I think even if the patient is asymptomatic in stage 4, we should do MRI brain, because at least if we don't have any brain lesion, at least at the point of revaluation, we can always reevaluate, because there could be some asymptomatic brain lesion which you may pick up at a later point of time, and then you are confused. So that correct. Whether the drug is working or not.
Yes, if possible, we should get it done in all the stage 4 cancer patients, even if they are not symptomatic. So not for treatment planning, but for future response evaluation. So that is a very valid point. So my next question would be to Dr. Amit. So Dr. Amit, keeping what all factors do you decide in an EGFR positive patient for deciding the first generation, for deciding the first line treatment? So is it the type of EGFR mutation, the site of mets, the number of mets? So apart from finances, what all factors do you decide for the first line treatment?
Yeah, apart from finances, the most important thing is if any brain mets is present or not. Surely if it's a brain mets, osimertinib will be the option in those group of patients. And apart from that, for exon 19 and 21, though is still both osimertinib and dacomitinib are the initial options in this group of patients. With exon 20, surely we have got different plethora of treatment now coming, whether it's a exon 20 mutation or insertion type. So, and further consideration during we give the options to the patient also regarding whether it's erlotinib plus bevacizumab is also an option which is in this group of patients.
Correct. So I think the most important clinical factor is the presence or absence of brain mets and the presence of which type of EGFR mutation. You have TKI sensitive mutation, or you have the uncommon mutations, or you have EGFR 20 insertion. So my next question would be to Dr. Kshitij, if he's here. So in what patients he'll actually use a combination of TKI plus anti-angiogenesis agent, and whether he has actually used it in clinical practice, and how comfortable is he to use this combination?
So I have used it in a few of the patients, but my preferred, I have a less use of anti-EGFR plus bevacizumab. That is erlotinib plus bev that I used in some patients, but I have a quite good experience of using a combination of TKI plus chemotherapy, and I can just comment on that as because I have using it. Whenever there is any abnormal mutation and patient is not affording from osimertinib, in that condition, I would I would like to use a combination. And if it is a clearly only exon 19 mutation, which is highly sensitive, then I would prefer to use a single agent TKI. That is what I practice.
So I think that's a very practical point. So I would ask the same question to Dr. Novak. So in what patients you will use a combination of EGFR TKI plus anti-angiogenesis agents? Because these they usually come to you that, sir, we have data of Cyramza plus erlotinib, please likho. So how frequently and how comfortable are you writing this protocol for your patient?
Dr. Rajat, I have not used, I am not using this, even though, we have the NEG 009 data, but the toxicity is very high. I am not comfortable as of now. I have not used, the combination of chemotherapy with Gefitinib or the relay data also. So as of now, I am much more comfortable with osimertinib as a single agent, very well tolerated. The patients, the quality of life is good. I am much more comfortable using with the third generation TKI rather than these combinations as of now, mainly because of the toxicities.
I think this is what I was trying to make a point, that even though we have a category 1 indication, I don't think that any of us are comfortable. Financially, it is also not that less toxic, and efficacy wise, it is not any better than any other TKI. So although this is an option, but I am not really sure when and where to use this combination as a treatment option. So my next question to Dr. Chaturbhuj. So what would be your first line treatment option for a patient who's EGFR exon 19 positive and for patients who is a L858R? So would it change for considering the type of mutation, or would it be same? Cost is not an issue.
So I think if you say cost is not an issue, so the answer will be definitely osimertinib, whatever the type of mutation is. Means the common two types of mutation, DEL19 and L858R. For uncommon mutations, I do prefer afatinib, not third generation TKI. But I would like to add one thing, that you already said cost is no issue. But if cost is even if the cost is an issue, so I would definitely keep in mind Gefitinib plus chemotherapy option, because we have a very good NEJ data which says 41 months of OS benefit, and the toxicity was also not much. So I don't know, means I don't find any reason to defer that data. So if the patient cannot afford osimertinib, I would be very, very comfortable with Gefitinib plus chemotherapy. Regarding anti-angiogenesis plus EGFR TKI option, I will definitely not prefer in any subset of patient till we have upcoming, because ramucirumab plus erlotinib data is evolving. I'm not very convinced that we should be using TKI with anti-angiogenesis as of now.
And would your treatment option change that Dr. Nagendra discussed in his previous presentation regarding the different EGFR 19 and L858R? So would you give dacometinib in particular subset, or would you still continue with osimertinib as first line?
I think we have a very strong evidence for osimertinib, so I would still continue with osimertinib.
Correct. So would any of my panelists differ in that? So would you use dacometinib in first line? Cost is not an issue. So I think most of us are comfortable. If the finances are not an issue, then osimertinib should be offered the first line TKI, irrespective of we have exon 19 or L858R. So
just one small comment about Flora. So we don't have any, means as Dr. Rajat, you focused on DEL19 versus exon 21 mutation, but I would like to tell you, I would like to emphasize on the racial part of that data. Asian population, there was no OS benefit with osimertinib. So that is something which again drives me to think about first generation TKI plus chemotherapy as a valid alternative option, particularly for Asian patients.
So this is so in your center, you worked at Rajiv Gandhi. So do you think that the combination of chemo plus TKI is actually cheaper than osimertinib, if the patient is paying from his own pocket, considering the chemotherapy cost, the administration cost, the doctor fees, hospital visits, the transportation charges? Do you actually think it is cheaper than osimertinib?
I think it's cheaper, because now we have a lot of generic drugs. So for chemotherapy also we have generic Pemetrix. That it's not like all the time you give Alimta. For Gefitinib we have generic Gefitinib. So I think if we use generic drugs, so that option is definitely cheaper as compared to osimertinib.
So for your patient, how much would be the cost of one chemo cycle? And you add on the toxicities and labs and the quality of life and the number of days lost in his work. So how much would be that?
Yes, so that would be significant. But if you ask me number means I can't exactly tell you what will be the cost of chemotherapy because it depends on several factors. But I don't think it will anyway. It will be less than half of osimertinib. At least I'm sure of that.
So I slightly
So
differ
can I
because I
comment?
think that the cost of chemotherapy drugs, if you include the toxicities, the patient's waiting time, the number of time, the hours lost while the patient and his family members, they are taking care of the patient, it is actually more or less similar. If osimertinib is 1.2 lakhs, then the cost of that would be similar to that. So that is my personal opinion.
I'll just
Yes.
I
add,
think that the administration cost in all corporates, it is more or less similar. So, so
can I
I don't
interrupt?
think that this is a cheaper option for
Yeah, can I?
in a non-panel patient. Yeah, please.
Yeah, so I little differ in opinion, means because I work in a setup that we have a daycare centers all across Mumbai and in Maharashtra in MOC. The cost of any chemotherapy is quite less. So it
So
is
yeah,
around just
because
25,000.
so you have that luxury. You can decide you can decide the cost of the therapy. We don't have that luxury. We have to fight for getting discounts.
But it is quite means if it is a 25,000 per chemotherapy and 1,20,000 for a drug, then it's quite different
Yeah, so it is
for
different,
us.
but you also need to consider that the patient has to come to the hospital. The number of hospital visits are more, the number of labs are more, the side effect is also more, and the waiting time, the number of hours lost in work for both for the patient and his family members. So these are all the factors that should
Yeah,
also be
agree.
considered. So my next question would be to Dr. Amit. So Dr. Amit, if the patient has an exon 20 insertion mutation, and you don't have the privilege of any clinical trial and you cannot procure the drugs like amivantinib, mobocertinib, so what would be your treatment of choice? So would you use osimertinib, dacomatinib, or would you use the chemo plus TKI?
Surely I'll go for a chemotherapy in this group of patients. Yeah,
So
yeah,
would you
sure.
chemo plus TKI or only chemo?
Chemotherapy is the best option in this group of patients as TKI has got a very less response if it's a exon 20 insertion mutation. So initially chemotherapy, and if on progression, a repeat biopsy and a mutation testing and further decision based on that.
So Dr. Kshitij, would you like to say anything different or same?
Yeah,
Chemo plus TKI.
yes, so I agree with Dr. Amit Kumar, but I have used in certain patients a combination of afatinib plus chemotherapy, and it has worked well in exon 20. And in the continuation, the maintenance phase, I continue with the PEM with afatinib, and he is doing touch wood good since last 1 year.
Yes, so theoretically, I also think that afatinib can be an option. So although there is no data of chemo plus afatinib, but I also think that this is an option for those patients who are not eligible for any trial. So Dr. Chaturbhuj, would you like to say something? Any experience with chemo plus afatinib?
I don't have any experience with chemotherapy plus second generation. I think in one patient I tried chemotherapy plus first generation TKI. I don't think that means the data for osimertinib plus chemotherapy is evolving, but I'm really sorry, but I'm not aware of any data of second generation TKI with
So
chemotherapy.
there is no data.
No data,
Obviously, there
it's
is no data.
extrapolation.
So it is a hypothetical question, and that you have exon 20 insertion, and there is no clinical trial available. What would be the best treatment option that you would choose for your patient?
I'm always afraid of telling that there is no data because data is so much evolving that you might not know some data and there should be some data. I would definitely prefer third generation TKI or first generation TKI plus chemotherapy.
Okay, fine. So I think we all agree that osimertinib should be the first line TKI, and you can see from this slide that the comparison of the PFS and OS with various other first and second generation TKI, the overall response rate is around 75%. Median PFS is 14.7 and the median OS is 34.1 months. So if feasible, then osimertinib should be the treatment option. So I think all the three factors are important in considering the treatment options: efficacy, safety, and quality of life. So I'm not sure whether any of you would be knowing this answer. So I have this question, because we can use afatinib in squamous cell head neck cancer, in esophageal cancer, and there is data of second line afatinib in non-small cell lung cancer, which is squamous cell carcinoma. So would you be tempted to use osimertinib in the same indications with afatinib in these settings? So maybe Dr. Novak can take this question. So I hope that you got my question. So Dr. Novak. So Dr. Kshitij can take this question. So you think that you can replace afatinib in second line squamous cell carcinoma lung, or in third line esophageal carcinoma, or maybe in head neck with osimertinib? Because theoretically it should work.
No, I can, because without any data, I think I cannot comment on this. Yeah. Let us see.
So yeah, so I don't think that anyone can tell this the answer of this question, but I think that should be evaluated, because we have data of afatinib, and osimertinib is a third generation TKI. So probably it should have a better response rate and better, at least PFS benefit in these subsets of patients. So osimertinib has demonstrated a significant improvement in PFS and across all the pre-specified subgroups, including those with CNS Met. So these were the patients that were also included in the FLORA study.
Basically, sir, regarding afatinib, it has worked in most of the rare mutations that it has been shown. But for osimertinib, still the data for acting on those rare mutations are still less. So might be more comfortable using afatinib still today.
So you think that the mechanism of action of afatinib in these subsets of patients is because of the rare mutation profile?
No, apart from this, in also rare mutations of different exon 20, also there rare mutations, afatinib is having some actions. But for osimertinib, this data is still not there.
So coming to the rare mutation, so what would be your treatment of choice, Dr. Amit, for a patient who has an EGFR rare mutation, which is not exon 19 or 21? So would you use dacomatinib or would you use afatinib?
Afatinib.
Or a combination of chemo plus TKI?
To leave afatinib or chemo plus TKI, but not still combining chemo with afatinib. It's the toxicity, I don't think so. Is
so choose one, dacomatinib, afatinib, or chemo plus gefitinib?
Afatinib upfront, sir.
So Dr. Kshitij, what would be your choice for uncommon EGFR mutation first line?
So I have told you that I have used with a reduced dose afatinib plus chemotherapy as an extrapolation from gefitinib plus chemotherapy. That is only in one patient. Otherwise, what everybody panelists is agree on it. A combination, as per the profile, combination of chemotherapy plus TKI will be my preferred option, or otherwise afatinib as a single agent.
Dr. Chaturbhuj?
Am I audible now?
Yeah, you are.
So I think in uncommon mutation, I made my point clear before also that I would definitely prefer afatinib, because we have evidence that afatinib works well in uncommon mutations. But if you talk me post progression on means after first line therapy post progression, so you were asking that in which subset of patient we will be preferring anti-angiogenic drugs. So those are the patients, I think, with TP53 mutation. So patients who has got concomitant TP53 mutation with EGFR. So these are the patients who do worse.
So you will use afatinib plus anti-angiogenic. Am I getting you wrong? So
yes, no. It's means there is some data, relay data. So relay data, it says that if the patient has got concomitant TP53 and EGFR mutation, then a combination of anti-angiogenic drug along with EGFR TKI, it do well.
But I don't think that afatinib was there in that study.
No, not afatinib.
So basically, you will also extrapolate the data, right, Dr. Kshitij? Like yes. Dr. Kshitij did with chemo plus afatinib.
Yes.
So you will explain the patient first that there is no data, but you are more keen to add afatinib plus maybe ramucirumab. Okay. So I think these were the questions that I wanted to ask, because we have been discussing all those things. So
am I audible? There is one patient in just with me having exon 19 mutation. Along with that, NGS was done. It is a PIK3CA mutation. So I just want a panel's opinion. What should be the treatment of choice then? Because I haven't seen PIK3CA mutation in lung, but it is there now. Any change in our line of treatment, or what everybody thinks?
So this question is directed to panelists. Anyone can take this question.
Upfront, even if PIK3CA is present, we are not going to change the therapy based on that. It has got different connotations in different ways. Though in the breast, it is surely we are going to use it, but might be in the later lines when you have exhausted all your options, then one can plan the therapy for PIK3CA directed therapy.
I agree, but chemo plus TKI, or just want to use TKI?
I think so. TKI is the.
So I think in breast also PIK3CA we don't use upfront Pluvicto. We reserve it for later lines. So I think it will be a prognostic marker, but I don't think that we can change the treatment.
Exactly. Yeah. So in breast also means, as you said, so PIK3 mutation is something which is present in germline. It just converts a poor prognosis, but it doesn't mean that presence of PIK3 mutation means we alter our existing standard of care. So you did NGS and you incidentally picked it up. So just imagine a scenario if you would have not done NGS, and if it would have been. So I don't think
what was the NGS that you did? You did foundation, because the NGS lung panel, they don't cover PIK3CA.
No, I did it from our normal lab only. They have started doing more extended panel of lung. So they cover a lot of mutations. In that, they found this mutation. It was not foundation, it was an Indian lab only.
Okay, because most of the NGS lung panel, they don't do PIK3CAs. At least I am not aware. So, Dr. Chaturbuj, can you explain this slide? So, do you think that giving dacometinib reduces the chances of osimertinib in the second line?
You are asking me to explain your slide. Okay, I will.
Yeah.
So, giving dacometinib will increase overall survival with osimertinib. I don't think.
Actually, I was trying to ask. So, do you think that sequencing afatinib followed by osimertinib is better, or giving dacometinib followed by osimertinib is better?
I always feel that we should use upfront osimertinib, because once we don't.
If it is not used, so if it is not used, out of the two, afatinib plus dacometinib, which one is the better? If we want to reserve osimertinib for the second line? Patient बोलता है मेरे पास पैसे नहीं है डॉक्टर साहब 6 महीने बाद आ जाएंगे तो what do you use?
I think I will use afatinib first, not dacometinib.
So probably I will also use the same, because we have only 10% of the patients in the dacometinib arm who have received osimertinib, whereas these patients are much more in the afatinib study. So I would also be more comfortable using afatinib in the first line if the patient is not able to afford osimertinib and is a candidate for osimertinib in subsequent lines.
Sorry for intervening. You have 3 minutes left to conclude.
Yes, I'll finish in 2 to 5 minutes. So this sequencing, I think we have discussed. So this sequencing, so this is a repetition of the slide again. So this is an important slide. So this slide is showing that not all patients who progress on first line EGFR TKI, they are able to receive a subsequent second line treatment. So it's very important that whatever we decide for the first line, it should be the best based on whatever evidence we have. And the second line should not be the priority for deciding the first line treatment, but yes, it should always be kept in mind. So based on whatever studies we have, the FLORA data is the most impressive. With its flaws, it is still the best data that we have in the first line setting. So the NCCN recommends all the available TKI as category 1. It recommends Erlo plus Cyremza and Erlo plus bevacizumab also category 1 indication. But it has mentioned preferred category 1 is osimertinib.
Dr. Rajat sir, excellent presentation, but another 2 minutes to conclude, please.
So I think I'll conclude my presentation. So any questions from the audience? Any questions from the panelists?
So just one question, sir. So for dacometinib, in which patients you are going to choose? So where are you keeping in your practice dacometinib?
So I'll choose dacometinib for those patients who does not have a chance to take osimertinib, whether in first line or in second line.
So if the patient means, you asked a very very difficult question that I have never encountered in my practice. I have seen many times 6 महीने में patient के पैसे खत्म होते देखे, but I never heard that 6 महीने के बाद पैसे आने वाले हैं.
नहीं हम आते हैं पेशेंट आते हैं, डॉक्टर साहब थोड़ा अरेंज कर लेंगे हम, थोड़ा टाइम हमको दे दीजिए.
6 महीने में तो हम लोग खत्म कर देते हैं बेसिकली.
अरेंज करते हैं ना दे. So I think before concluding, I'll ask one of the questions from the slide to Dr. Chaturvej. So in what patients do you give brain RT to your EGFR positive patients?
So if EGFR positive patient not taking osimertinib, brain metastasis, if symptomatic, definitely radiation followed by EGFR TKI, first or second generation. If patient is taking osimertinib, brain mets are asymptomatic, I would definitely start upfront with osimertinib and will not offer RT.
Okay, so those patients who are not symptomatic and those who are on first line TKI, then you would definitely give RT?
No, asymptomatic brain mets
treated with first line TKI only.
Yeah, treated with first line TKI. If it's asymptomatic, I would look at the quantum of disease. If it's a very small asymptomatic brain met, I would rather keep a close follow and start on first generation TKI.
Okay, so basically osimertinib, you would not like to treat asymptomatic patients, and even symptomatic, would you like to treat with RT in case of osimertinib?
No. In symptomatic brain mets, definitely we can start with osimertinib.
So yes, so I think in patients who are on osimertinib and those who are not symptomatic, we can leave the radiation option. For most of other patients, RT is definitely a treatment option. So I think with this, I would like to conclude my presentation. And there are some takeaways from this presentation that T79M resistant mutation post first line therapy cannot be predicted. So first line treatment should be the best option. And not all patients receive the second line and subsequent lines of therapy. And osimertinib is the only TKI to have shown a statistically and meaningful OS benefit. And the PFS and the OS benefits have been seen across all the subgroups. It is a well-tolerated drug. And given the feasibility, it should be given as the first line treatment option. Thank you so much.
Thank you, sir.
Thank you, everyone. Thank you.
Over to Tarun, over to you.
Hello. Yes, am I audible?
Yes,
Yes, sir,
yes.
you are audible.
Yeah. So now for the next session, I invite Dr. Vikas Goswami. Dr. Vikas Goswami is Associate Director, Department of Medical Oncology at Max Super Specialty Hospital, Delhi, and he is going to talk about the management of first-line ALK positive non-small cell lung cancer. Dr. Vikas, sir, good evening.
Hello, good evening. How are you, Dr. Rajat?
Good, sir. Good. I hope you're doing well. Over to you, sir.
Yeah, I'll be sharing my slides. Dr. Rajat, is my screen visible?
Yes, sir, it is.
Okay. So I'll be talking about the management of first-line therapy in ALK positive lung cancers. This is a Pfizer-sponsored session, and the slides have been given by Pfizer. And more specifically, I'll be talking about the data, upcoming data, which has shown the benefit of lorlatinib, which we were giving till now as a second-line drug in the first-line therapy. So very briefly, we know that lung cancer is common and it has not very great numbers in terms of 5-year survivals. And the numbers are only increasing. And in terms of percentages, EGFR percentage positivity varies across the world. In India also, North India, South India divide is there. This paper by Dr. Behra et al. published in 2016, showed EGFR prevalence of about 23%, and second most common mutation was ALK, which was about 7.9%. So ALK is not uncommon. Second most common and specifically seen in adenocarcinoma. Less smokers, never smokers tend to occur in younger patients, and diagnostic techniques are available. The sequencing was that it's a relatively new mutation. It was diagnosed in 2007. Crizotinib first came into the market in 2012. Very quickly, we developed the second generation ALK inhibitors in the form of alectinib, ceritinib, brigatinib. And then came the third generation lorlatinib, which was approved for second line in 2019. And last year, it got approval for frontline setting. And that's the data I'll be discussing. So the issue with ALK inhibition is that with first generation therapies, there is issue of drug resistant clones developing quickly, and second issue is the issue of brain metastasis. So the patients who don't have brain metastasis can develop tumor resistant clones specifically in brain. So both these issues kind of are addressed by lorlatinib, which is a selective ATP competitive, highly potent third generation ALK inhibitor with a 75% penetration to the brain. And this is the reason why these two specific things, the points which I mentioned, are specifically targeted by lorlatinib. So there are slight differences in the biochemical setting of crizotinib versus lorlatinib, and that causes effective CNS penetration and retention, and it binds and increased binding affinity to the ALK resistant mutations. So this was the CROWN trial. This was published in NEJM in 2010-20. Here in stage 3B, stage 4, ECOG performance status 0 to 2, asymptomatic treated or untreated CNS metastasis patients with more than one extracranial measurable targeted lesions were randomized into lorlatinib 100 mg versus, now this was in comparison to crizotinib. If you see most of the trials there, the comparator arm has been chemotherapy. Here, this was specifically compared with lorlatinib, and the primary endpoint was progression-free survival. Secondary endpoints were PFS by investigator, ORR, and quality of life and safety issues. So almost 300 patients were randomized between May 17 to February 19, roughly 150 each, specifically 149 for lorlatinib and 147 for crizotinib. They were randomized, and median duration of follow-up was almost year to year and a half. Both the arms were balanced in terms of sex, performance status, smoking status, and we had Asian population also roughly 44 patients each in crizotinib and lorlatinib arm. So in terms of PFS, the graph started separating. Now, remember, this is comparator arm is crizotinib, and look at how the graphs are separating as early as 4 months, and an astounding hazard ratio of 0.28 in favor of lorlatinib. Needless to say that it was significant. P-value was significant, and the median PFS has not been reached for lorlatinib. And the graphs for progression-free survival by investigator were even wider, with a hazard ratio of 0.21, and the median PFS again not reached. And if we see the forest plot, all the subgroups, the rectangle is significantly on the left of unity in favor of lorlatinib. So whether it is brain mets, Asian or non-Asian population, male, female, age, smoking status, all of them were in favor of lorlatinib. Again, response rates were better for lorlatinib, with almost 3/4 patients responding, and median duration of response for crizotinib is 11 months, while lorlatinib, it has not been reached. The speed of response, interestingly, that means the median time to response is equal in both, that is roughly 2 months. So intracranial activity, again, we expect lorlatinib to perform better, and there it is. Whether the patients with measurable or non-measurable baseline brainstem lesions, both the lorlatinib fared better and superior in terms of crizotinib for subsequent brain mets development. And here the number of patients with CNS progression-free survival, again, lorlatinib was better. However, the overall survival hazard ratio is superior for lorlatinib. However, the confidence interval is crossing unity, so it's ranging from 0.41 to 1.25. So possibly more data is required. Possibly the reason is that subsequent to lorlatinib, we don't have too many options. And okay drug to tolerate. Grade 3, grade 4 side effects were seen in 108 patients, and serious side effects were seen in 51 as against 39 patients. Fatal side effects were both the arms had 7 fatal side effects. That means 5% of the population. So dose interruption was almost common. So by and large, side effect profile for serious side effects is common. Interesting side effects for lorlatinib, one needs to know, are deranged lipid profiles in the form of hypercholesterolemia, hypertriglyceridemia, and edema. So lipid profile, one needs to be aware. The rest of them, by and large, similar kind of side effect profile, with some side effects with less propensity, like decreased appetite. We all know crizotinib causes decreased appetite. So a patient who's already on the asthenic side, maybe lorlatinib can be of use. Global QOLs, maximum change from baseline score, p-value was significantly better for lorlatinib, in favor of lorlatinib. So to conclude, lorlatinib resulted in significantly longer PFS with higher overall response rates, improved quality of life indexes. So safety profile of lorlatinib was similar to crizotinib, and by and large, the authors concluded that this very much puts it in the frontline setting. So in view of this study, now lorlatinib is approved as a category 1 recommendation, along with brigatinib, alectinib, ceritinib, and crizotinib, they have said used in certain circumstances. The management of lipid profile derangement involves the use of dietary modification, exercise, and some statins. So rosuvastatin, pravastatin, and pitavastatin are recommended, and there are drug modifications, and how much and when to start is as per the drug insert. So by and large, again, fairly well tolerable drug. So to conclude, I would say that the way osimertinib changed the paradigm, possibly lorlatinib in first line setting certainly is a new benchmark. The issues which we face with osimertinib, for example, what next after osimertinib? Should we be reserving osimertinib, which is the benchmark drug, for a second line versus first line? The same issues are going to crop up with this kind of medicine. Thank you.
Thank you, Dr. Vikas sir. I would like to ask you a question as to what is going to be your first line therapy now in a ALK positive metastatic NSCLC. So on one hand, we have a drug called alectinib and the other is lorlatinib with a patient having brain metastasis, and for example, there is a patient who does not have upfront brain metastasis. So is your choice of treatment going to be any different in these two patients? I'm talking about ALK rearranged metastatic NSCLC, brain mets or no brain mets, and the upfront setting.
See, for brain mets, we have one more drug which is affordable, that is ceritinib. Now, if you're asking the comparator arm as crizotinib, I would certainly not choose that if a patient has brain mets. The question is that, okay, if the patient doesn't have brain mets, then what? That is a more difficult situation. Now, understand that the first line failure was roughly around 10 to 11 months for this thing, crizotinib. And first line failure for ceritinib was around 26 months. And first line failure for lorlatinib, I think, is 30 months plus in first line setting. First line failure for alectinib, I think, is 34 months and brigatinib is 24 months. So yes, coming to your question specifically, if you're asking me the comparator arm with crizotinib, if I put crizotinib followed by, let's say, lorlatinib in second arm is 6 to 7 months. So crizotinib followed by lorlatinib is inferior to lorlatinib in first line setting. Crizotinib followed by lorlatinib is inferior to ceritinib alone. So I think it's time to rethink what should be our first line choice. For me, possibly my first line choice might be lorlatinib or ceritinib over crizotinib. That's how I think. There are no clear answers to your question.
Okay, right. So my actually what I was pointing towards is that lorlatinib having very robust intracranial response rates, and patients who have got brain metastasis, we do know that these patients will have lesser extracranial PFS also as compared to a patient who does not have brain metastasis. So in a patient who is having brain metastasis, even though we know that the PFS in the CROWN study has not been reached till now, whereas the PFS in the ALEC study is to the tune of 34 months, is it possible that we choose lorlatinib over alectinib for patients who have got upfront brain metastasis? The response rates are huge for lorlatinib in the CROWN study.
So if you are comparing, so question is now comparison with alectinib.
Yes. Although of course cross trial comparison.
Yeah. So okay. Again, I think lorlatinib, the first line data was about 35 to 36 months, and alectinib was 34 months. Alectinib followed by lorlatinib, add another 6-7 months. Lorlatinib followed by what, we don't know. But still, in terms of, so I haven't used alectinib. I have used lorlatinib in few patients. The tolerance is okay. So possibly I would choose lorlatinib as first line.
Okay, right. Thank you so much for a very nice presentation. So now we move to the next topic, and the next topic is going to be turning the tides for stage 3 NSCLC towards the curative intent. And to talk about this, we have with us Dr. Deepak Mulachkar, who is a consultant medical oncologist from RR Hospital, Delhi. Dr. Deepak, good evening. Over to you.
Good evening, Dr. Bajaj, and rest of the audience. So I'll start to share my slides. I hope I'm audible and my slides are visible.
Yes, they are.
Thank you so much. So, right, this, I think, the incidence, the death, and we are all aware about what is the mortality and morbidity that is caused by lung cancer, and I'm sure all of us are dealing with it. So now if we look at the distribution of the disease, all of us know that we tend to see the localized disease quite low. distant metastatic disease is the most common. But even then, there's this locally advanced group, which includes about 35.3% of patients. So if we look at the approaches to management of localized advanced stage 3 disease, so of course, multidisciplinary team, whether it's resectable, not resectable, what is the nodal status, how are we going to prove the nodal status? And after all that, when we say that the treatment is an unresectable NSCLC, then of course the data is for concurrent chemoradiation. Wherever you are unable to give it, probably because of the patient's performance status, then of course you go for sequential chemoradiation. And going through the same algorithm, if you look at it from the ESMO, they again look at the end stage surgery, no surgery, or probably N3, then we have a non-surgical treatment modality. So now it's a very funny setting. We say it's a stage 3. We explain it to the patient that yes, it's a stage 3 lung cancer. No, it's not stage 4, because the patient wants to know if it is stage 4, what stage is it? And then we see our intent of therapy is curative. But for a curative disease, we have a median survivals in months after we have obviously given them a curative therapy with probably chemoradiation concurrent, and then we find the PFS rates. Whether you, it doesn't matter what you use, which regimen you use, or whether you in concurrent regimens, we come out to the same, around the same, more or less the median OS, somewhere around about 2 years. Now, this is not a very good thing for a disease where we are saying that our treatment option is curative. Now, well, this was a problem and all of us recognized it. We decided how to go about it. Maybe extend the chemotherapy a little more. So we have tried docetaxel, we have tried docetaxel, and probably increase radiation, maybe give Geftinib later on again, but we did not get anywhere either with the PFS or with the OS. With none of the values you see here give us confidence in telling to the patient that yes, we have a curative option for you. So now, like this is the slide which again highlights the same thing what I have been saying, that with the intent of treatment, that where we say it is curative, the 5-year OS is around 15 to 25%. So how to build upon it is what we are all looking at. Now let's look at the immunotherapy. I'm quite sure that all of you are aware with all these slides, you are aware about how durvalumab works. But probably post-radiation is there's a tumor breakdown. Probably there are more new antigens, and probably you have more number of antigens that your T cells can act upon. And under these circumstances, probably overcoming PD1 with PDL1 interaction with the use of a antibody, this looks like a very good. Looks on paper a very good proposition. So keeping that in mind, probably a study was in place, and this is the Pacific trial that was done. Stage 3 locally advanced unresectable, and those who have not progressed following platinum-based CCRT. So it was a randomization 2:1 durvalumab versus placebo, and it was given for about 12 months. The primary endpoint was PFS by BICR and OS, and secondary were ORR, safety, tolerability. So if we look at the baseline characteristics, we find the baseline characteristics to be almost well matched. One thing probably which people have debated earlier on this forum right now here is what to do about those with EGFR mutation status. We don't have an answer, but everybody's made a point that yes, it's only about 6% of the entire study had EGFR positive mutation. However, there were about nearly 26-27% whose EGFR's mutation status was not known. So how do we deal with that is probably something that has already been discussed, but we'll just go through the specific study. Now, again, we looked at whether the PDL1 expression was there. Then what was the histology? What was the prior chemotherapy? Was it induction chemotherapy or concurrent with radiation therapy? So if we look at the placebo, we look at the updated 5 years overall intention, 5-year survival in intention to treatment. Then we look that these graphs, if you look at them compared to durvalumab versus placebo, the OS, median OS is about 47.5 months compared to 29 months for the placebo. And you have a hazard ratio of death of 0.72. And which I think is pretty significant for the amount of follow-up that we have had with this patient. So it is, yes, if we look at the progression-free survival again, we look at the durvalumab versus placebo, we have 16.9 months versus 5.6 months for the placebo. Again, we see about 1/3 benefit at about 5 years. So there has been 2 years, 3 years, 4 years data, and they have continued to show about the benefit of specific regimen. That seems to be the 5-year data seems to show that there is a continued benefit of with specific with the addition of durvalumab. So if we look at the pre-specified subgroups, almost other than the EGFR group, which I don't know how we can interpret it with the number of patients that were there, that more or less it is there across the various subgroups of interest, we find that whether more or less durvalumab does better than the others. This is PFS benefit. If you look at the PFS benefit, again, if you have to just take away the the EGFR status out of it, and then we again see that more or less everybody tends to derive benefit of durvalumab. Now, where is the disease progression? Where does the disease come back when we look at whether it is intrathoracic only or extrathoracic only? So if you look at it, there is about decreased rate of progression in durvalumab as compared to placebo, and majority of the progression of durvalumab was intrathoracic. Now, it also improved the time to intrathoracic progression when compared only to placebo. So though the disease comes back in a localized setting, in an intrathoracic setting, in the presence of durvalumab when we compare to placebo. Now, after about what do we do with what do the patients receive after discontinuation of durvalumab? Durvalumab arm, around 41% of patients and about 54 patients compared to the placebo, only about 41% had received some therapy. And in both the arms, it was this subsequently systemic therapies were used, by whether it was in the durvalumab arm or the placebo arm. Looking at the safety, yes, we all are aware about the safety of immunotherapy, and I think more or less we are all learning how to deal with them, and more or less I can be confident in saying most of us can manage the side effect profiles of immunotherapeutic drugs. However, radiation, whether it is radiation pneumonitis or whether it is immune-related radiation pneumonitis, we tend to have a higher percentage of pneumonitis in durvalumab compared to placebo arm. This is something that we need to keep in mind. Now, how does it how does it function in a real world? We have this specific R real world data, and we had this presentation which was available to us. So if we look at the various in the real world data, they analyzed about 1400 patients, and if we look at it, the patient characteristics, the majority of the patients were less than about 75 years of age, and merely a small percentage received about sequential chemotherapy. Rest, more or less, patients have received concurrent radiation and chemotherapy. If we look at the median PFS, is about 20 21 months compared to about 16.9 months with durvalumab arm. And the discontinuation rates, you more or less we look at it that it's no new adverse signals were generated, and the adverse events are more or less comparable with what was there under the trial settings. So, and of course, the steroids were administered for the most of the in about 71.3% of cases. So if you look at it, there's an improvement about 11 months in median PFS with durvalumab compared with placebo, and a similar benefit under real world settings. And the median OS is again 47.5 months for durvalumab compared with about 30 months for the placebo. So around about 6.3% pneumonitis being the cause for treatment discontinuation. This is something that we have to keep in mind, and probably be more vigilant about this particular side effect when we are managing our patients with durvalumab. So coming to the key takeaways, this is one of the drugs which has shown that the median OS was definitely improved by use of durvalumab compared with the placebo. And there was improvement even in the PFS. But like I said, probably we will have to keep a watch on that pneumonitis part. With this, I've come to the end of my talk. Thank you so much for your attention. Hello.
Hello, Dr. Rajat, you are there, sir? Hello. Good evening, Dr. Resham Puranik, ma'am. Good evening to you. Dr.
Yes,
Rajat,
good
you are
evening.
there? Dr. Rajat, you need to unmute yourself, please.
Yes, yes. Actually, I lost my connection for 2 minutes. Right. So, is Dr. Deepak there?
Yeah, I finished about, let's say, about a few seconds back.
Yeah, yes. So that was the time when I lost my connection. Sorry. So, Dr. Deepak, I was listening to your talk, but I lost last 2 minutes of your talk. But then I think that all of us believe that durvalumab is going to be the standard of care for sure, and it has been the standard of care since the time this Pacific trial has come post CTRT. Is there any subset where you would not like to use durvalumab? And when I say that, I am really referring to the EGFR positive or the ALK positive subset, which was about 6 to 7% in this trial. So before using durvalumab, are we really doing EGFR and ALK in these patients and then subjecting these patients to durvalumab if both of them are negative? Are you doing that in your practice?
Yeah, I tend to do the NGS panel for lungs moment the diagnosis comes in. And I didn't have this in mind when I started doing it, but now after looking at the data and probably looking at what the data of osimertinib has come out, I would be a little hesitant in starting durvalumab in people who are EGFR mutated. And even in ALK, there's this ALK translocated patients also. I think that we need to go a little slow, and we need to study this before we give durvalumab across the board.
Yes, exactly. So I think that is a very important message that should come across. Right. Thank you so much for your very nice presentation.
Thank you.
Yeah. So now we move ahead and from durvalumab now to extensive stage small cell lung cancer. What is the role of evolving immunotherapy in SCLC is what we are going to talk about in the next 10 minutes. And to do that, we have with us Dr. Reshma Puranik, medical oncologist from Pune. Dr. Reshma, good evening.
Good evening, Dr. Rajat, and thank you so much for inviting me today. Can I start?
Yes, please.
Okay. I hope my screen is visible.
Yes, it is visible.
Okay, okay. So a very good evening to everyone. And moving on to small cell lung cancer now. So like we all know, I hope my slides are moving. So like we all know, the bulk of our lung cancer patients are non-small cell lung cancer. So it is the 15% subset which attributes to the small cell lung cancer. But whenever we have a diagnosis of this, we all are very worried about the prognosis. The prognosis is really dismal. Most of our patients don't make it beyond the first year. So we have always been looking out for more and more treatment options for this patient. So like we all can see, bulk of our subset is non-small cell, the smaller subset is small cell, but most of our patients are elderly, they are smokers, and many of them, at least 50% of them may have brain mets at presentation or eventually going to develop it. So approximately 2 in 3 patients have extensive stage of diagnosis. Most of them are extensive stage and not limited stage, and the life expectancy is less than a year when treated with the backbone EP alone. So 2 in 3 patients have extensive stage small cell at diagnosis, and their poor prognosis when taking EP alone, the current first line standard of care of treatment. So the survival rates are really, really poor. So what, as of now, what we had for all these years was a platinum based doublet backbone, and it was given for 4 to 6 cycles. And if there was residual disease, it was followed by thoracic radiation and followed by plus minus a PCI, that is a prophylactic cranial irradiation. But in spite of this background, we did not achieve a very good survival rate. So this is the treatment evolution of small cell lung cancer. So earlier, which had a platinum-based platinum-based doublet backbone, which progressed, and eventually we had a radiation. Then we had other agents coming up like topotecan, irinotecan. Then there was few roles of docetaxel, paclitaxel. We also have used the regimen CAV regimen, CEV regimen also in this. But no matter whichever medicines we used, we really could not achieve a very great survival. So now in the latest era of immunotherapy in 2018-2019, we are having molecules like nivolumab, atezolizumab, durvalumab, which are approved. So what is the total intent of talk today is that when we are going to add immunotherapy to the main chemotherapy backbone, what are the things that we are achieving? And we as clinicians have the main doubt as to which molecule to add, which of the immunotherapy medicines should we add, and which is the best one to choose. So we're going to go into a little details of the 2 trials of the 2 main molecules, and then we're going to see which molecule out of them is a better choice. So since EP was established as a standard of care nearly 30 years ago, there has been limited progress until now the era of immunotherapy. So many new therapies were not able to show any meaningful improvement until the era of immunotherapy, in which some improvement is now is what is seen, and some new hope is what we are able to give our small cell lung cancer patients. So in the earlier care, if you saw, it was a platinum-based chemotherapy doublet for 4 to 6 cycles, followed by PCI radiation. And if the patient was if the patient relapsed with within 6 months or less than 6 months. So we could have a platinum rechallenge or some other molecules. And if the patient was refractory, we were hardly left with any options. And at that time, immunotherapy and all the molecules were literally almost in category 3 options even initially in the initial period. But then almost most of the patients did respond, but they progressed within 4 to 5 months and their expectancy was less than a year. So the PFS was not very good. Within they did well to now small cell lung cancers are really responsive to chemotherapy, but the response doesn't last. So they relapse within the next 5-6 months and resulting in an overall very, very poor survival rate. So newer treatments to improve the duration of response and overall survival rate were very, very essential. So immuno-oncology products now have been added to this etoposide, carboplatin, cisplatin background in many of the countries right now. So now we have first line, that is the NCCN category 1 recommendations, in which we can have the platinum doublet with either durvalumab or atezolizumab in combination with this for 4 cycles, followed by the maintenance. And so these are the newer indications that NCCN has also approved, and we are in this small talk. In the next 10 minutes, we are going to discuss the important trials which led to this approval and the differences between these two molecules. And now we have category 2A. Now we have this NCCN category 2A if IO has not been used in the first line. So these molecules are also can be used in the second line. But what is the issue is that I feel the patients of small cell should get the best possible drugs in the first line itself, because that is the main chance that they have of giving us some good responses. Because if you reserve the immunotherapy molecules for the second line, hardly 50% of our patients are going to be alive by that time. So it is the first line therapy that is your only chance where you can give them the best possible treatment so that they carry on for a lot of time and their survival and PFS improves. So reserving immunotherapy for second and third line would not be a very good choice for the small cell lung cancer patients. So most of the patients do respond well to atezolizumab. Now coming to the two main molecules that are approved, that is atezolizumab and durvalumab. So the trial which led to approval of atezolizumab was the Empower 133 trial, and the trial which led to approval of durvalumab was the Caspian trial. So we're going to study in short the differences between these two. So the first trial, in which there was a combination of atezolizumab plus the EP, the data, also this trial did show a survival advantage. So 60% of the patients did respond to atezolizumab, objective response rate of 60%, but the relapse rate was still, that is the PFS was almost 5 months. And what is the problem with Empower 133 trial is that we have a follow-up data of 2 years, and beyond 2 years the data is still pending, but the curves, if you observe in this table, they are showing a little convergence. So the 2-year OS is 22%, but the curves are trending towards a converse, and as of now we are not yet having a long-term survival data. So we need more data to show the efficacy of atezolizumab. So approximately 2 in 3 patients have ACLC at diagnosis. Current survival data is limited to 2 years, and long-term benefit is still at the present not clear. So despite improving outcomes, treatment with atezolizumab can be used in combination with etoposide and carboplatin, and survival data above 2 years is currently lacking. So moving to the next study for durvalumab. So Caspian was the first and the approved IO regimen for extensive stage to allow up to 6 cycles of EP in the control arm and use of cisplatin or carboplatin. So what we are trying to show here, we as clinicians, we are looking at all this data in an unbiased way. We are not biased towards any molecule. What we are seeing is the actual facts and figures that the trial data is showing us. So what was the advantage of Caspian trial over Empower was that it allowed both use of cisplatin, carboplatin, and the control arm use of 6 cycles was allowed. So this more often reflects the clinical situation, that is many of our patients do receive 6 cycles of platinum and platinum based doublet. So the control arm, we could say, is very robust and is more comparable, more often reflects the real world situation. So the Caspian trial had these 2-3 advantages, that it allowed up to 6 cycles of EP in the control arm, as well as it allowed use of cisplatin as well as carboplatin. There were 2-3 more points in which I can point out towards the Caspian trial was that we had a choice of platinum. So we could use, if we wanted to avoid neurotoxicity, nephrotoxicity, we could use carboplatin instead of cisplatin. And if we were very, very fearful of neutropenias and all, then we could use the cisplatin. So both the molecules were allowed. Patients with asymptomatic or treatment brain mets were included. So this was one more difference as compared to the Empower trial, in which treated brain mets patients were not allowed. So again, the real world scenario was not reflected. We would have a lot of patients with treated, many of the patients would just come with brain mets, have radiation and come. So then it becomes difficult not to include them. So we can't really exclude them, considering that the incidence of brain mets is so common in small cell lung cancer. And plus the control arm was also very good because it allowed 6 cycles, and PCI was also allowed as a investigator's discretion. So what was the Caspian trial all about? Included around 800 patients with a good performance status, life expectancy more than 3 months, along with the RECIST criteria in which there were target lesions which could be measured. And it was divided into 3 phases. So it was a durvalumab plus EP combination for 4 cycles followed by maintenance. Then there was a comparable arm of EP only, that is the arm which we had been using all these years. And there is one more investigational agent, I think that is tremelimumab, and it has been, they are now also investigating this agent, whether addition of this tremelimumab to the durvalumab, whether it also has any survival advantage. As much as I know, up till now, the newer agent has not been able to prove any benefit. So we will be concentrating on the first 2 arms only. So Caspian reflected the clinical data, which was more closely aligned with how patients are treated in the real world, is what I was just discussing. So what we can see is the difference over here. Only carboplatin was allowed. Here both the platins could be used. Patients with brain mets were only eligible if they had prior treatment. Patients with asymptomatic, untreated and treated brain mets were eligible. And here only 4 cycles was allowed in the control arm, whereas over here 6 cycles were allowed. So this was the main differences between the 2 trials. And durvalumab EP is the first and only approved IO to demonstrate statistically significant sustained improvement in OS at 12, 24 and 36 months. So the important thing is what we saw in Empower trial was we had data up to 2 years, and even at 2 years, the curve seemed to be a little converging. But if you see that with Caspian trial, you will see that the curves do show a separation even at the level of 3 years. We have data up to 3 years and beyond. This trial was started in 2017. The patients were enrolled in that year. So we have a follow-up data. We have updated results even last year. We have data of more than 3 years, which is showing a consistent improvement in survival. So 3 times more patients alive in this arm as compared to the EP arm. So the survival was 12.9 versus 10.5 months with the HR ratio of 0.7, which is significant. So the clear separation of curves is obvious, and with a notable fattening observed from 27 months onwards, and estimated percentage of patients alive are 3 times more than that. So we have quite a percentage. Imagine we to a few years back, month analysis also, the odds ratio was 1.53, and the durvalumab EP arm had an objective response rate of 67%, and as well as the median duration of response was 5 months. So somewhere we had that durability of response also over a period of 2 and more than 2 years. So 3 times more patients remaining in response at 24 months in the durvalumab arm. So a sustained improvement in PFS also. So all this while we were talking about OS, even as far as PFS is concerned, nearly 4 times the number of patients were progression free at 24 months versus 10% of them with and 10% of them with ongoing treatment at 3 years. So how many percentage of our patients could actually continue durvalumab for a period of 3 years was a 10% figure. So more than 3 times the number of patients were progression free at 12 months, nearly 4 times the number of patients were progression free at 2 years. And 10% of patients were continuing treatment at the 3-year cutoff. So we have data of 3 years, and still 10% of patients were able to take this durvalumab for 3 years and more, and HR of 0.8, which is significant. So this is where the durvalumab arm was much better as compared to the EP arm. So the OS based on baseline. So if you take the
Ma'am,
patient,
sorry to interrupt, but you need to
okay.
conclude, please. Yeah.
Okay, fine. So I'll just quickly, so the brain mets patient also showed a consistent improvement. A small point on the safety profile. The safety profile of durvalumab also did not show any much increase in the adverse events as compared to the EP arm. And many of the patients were still able to continue this. So the discontinuation rates attributable to the immunotherapy was not much is what I want to tell you. And the adverse events were almost equal in both of the arms. So durvalumab per se did not increase the adverse events to a significant level. And otherwise, I'll just continue. The quality of life also was not deteriorated. The quality of life was maintained in this patient. So we have the quality assessed life years, which were also comparable. And key study differentiators, like I already told you, PCI was allowed in experiment up to 6 cycles of chemo were allowed. So these were the differences that also we discussed. So this is the NCCN. It has approved both the molecules as category 1 recommendations. And coming to the conclusion, last slide, the first line durvalumab BP has shown a sustained improvement in OS with a robust control arm and allows 6 cycles of BP use of PCI as compared to the results of the other trial. Durvalumab only approved IR showing flexibility of using either cis or carbo. Benefit was observed across all subgroups. More than 17% patients are surviving even after 3 years, showing a prolonged survival benefit, high response rate and ongoing response at 2 years. It offers a convenient, and one more point which was missed in the slide was that durvalumab is once a month dosing as compared to atezolizumab, which is once in 3 weeks. And the safety findings are consistent with the known safety profile of durvalumab and EP. So I would suggest that at the data right now, what we have is it is definitely favoring durvalumab to some extent, and we are having this immunotherapy backbone to our platinum doublet, so we can offer our patients some sort of therapy along with the maintenance, and they will definitely have an improved PFS and OS rate. So I conclude my session, and thank you so much, organizers and Dr. Rajat, for inviting me.
Thank you very much, Dr. Reshma, for a very nice presentation. And what has been your experience for using immunotherapy in small cell lung cancer? Have you seen that it has made quite a lot of changes in terms of either response rates or survival in the patients that you used immunotherapy in?
To be true, Dr. Rajat, we don't really get many affording patients for immunotherapy, but having been used in hardly 1 or 2 patients would not be, I would not, it was not a very good way to call it as an experience of using these molecules, but definitely the patient, I could see that the patient had a good PFS, at least the relapse was not very fast in the patient, and the patient could continue it for a year or so. So the relapses which we see, as soon as we stop the doublets, we see the relapses are very common. So this patient at least could have a sustained response, and the relapse was delayed beyond a year. So that was one advantage, but hardly used it in 1 patient would not really getting much affording patients to use it in more patients.
Yes, right. I think affordability is a major issue there. Right. I completely agree. So thank you so much once again.
Can I answer that, Rajat?
Yes,
with
sir,
your
please,
permission.
Of course, sir. Please go ahead.
So we have had, I think, a very small experience of around 12 patients that we have used. 2 people have been long-term survivors. In fact, one lady has been a survivor for more than a year and a half. I will not name the drug that we use, obviously for a very obvious reasons, that it is following, it was against the Caspian trial, which you have said. So the problem is, again, the immunotherapy, we need some kind of predictive biomarkers. We have also just concluded a study on 200 of our patients. So there's a new classification of small cell lung cancer, the IHC markers, the classification. We are also awaiting results of that. We are submitting it to ISCLC also. So we are trying to figure out which patients actually respond well to immunotherapy. Again, the advantage was that people who do respond, they respond very well, but very few, 1 to 2 out of 12, small numbers.
And Dr. Ullas, just one more point. The trials which we saw, Caspian and Empower, in them the predictive markers were not, they didn't matter. It was irrespective of. Yeah. So we wouldn't want to check PDL1 or tumor mutation marker. They didn't correlate.
No. So no point in checking PDL1, no point in checking TMB. The new IHC classification which has come up, which is, we are going to probably tell you in another 2 to 3 probably months when we analyze the result. The other thing is the lady who has responded, the one patient who has responded, the maximum is a female, ex-smoker. So I think the age and everything doesn't really come into account over there.
Right, sir, right.
So point very well taken. And so I thank Dr. Reshma once again. So now we move ahead, and now we are talking about the panel discussion, the much awaited panel discussion about the management of rare mutations in lung cancer in 2022. And to moderate this panel, we have with us Dr. Ullas Batra, sir. Sir, good evening. He is the co-director and chief of thoracic oncology services in the Department of Medical Oncology at Rajiv Gandhi Cancer Institute, Delhi. And he is somebody who needs no introduction, but still I did that. And sir, I will like to call your panelists. I will like to call Dr. Manish Jain, who is the Director of Medical Oncology at Ruby Hall, Pune. Dr. Bharat Vaswani, who is a Senior Consultant in Yashoda Hospital, Hyderabad. Dr. Vikas Talreja, Consultant Medical Oncologist at Regency Hospital, Kanpur. And Dr. Udeep, has he joined? Dr. Udeep, who's
Yes,
Consultant Mumbai Oncocare Center, Mumbai. So, sir, over to you.
Okay, and thank you, Rajat. And I would also like to invite one more panelist onto this. You know who, Rajat. So Dr. Rajat is a dear friend, a colleague, and we worked together for 3 years when he was at RGCI. So Rajat, please be a part of the panel.
Yes, sir, please, I'm there.
And there was a question in the chat box, you know, has any, I think Nagendra had asked, has anybody used attenuated doses of durvalumab plus etocarbo? I haven't used oral etoposide, Dr. Nagendra, but we have given split etocarb. What we do is the performance status is very poor. We do split etocarb into day 1, day 8, and the results have been really reasonably okay. But again, the performance status. So one thing which we have realized in immunotherapy, Dr. Nagendra, is the performance status is the most important thing. Whether it is the first line or second line, and there's a published paper, I think we all contributed to that, was performance status 3 or 4 is the most important poor prognostic predictive marker for response to immunotherapy. So in a PS3-4, immunotherapy won't really act. This is not a targeted therapy which will respond in PS3, PS4. But yes, we have given weekly etocarbs and we have added immunotherapy onto that. So I hope it answered that. Thank you, Rajat, for the invite, and we had a nice discussion today morning. Hi, Bharat. Long time. 1 hour is a long time in oncology. Okay, and so I was asked to moderate in the last and the fag end of the conference about rare mutations in lung cancer. And my first reactions when I first saw the topic over there, and when it was yesterday night when I was making the presentation, was this. How do you define a rare disease? What is the approximate incidence of patients living with rare diseases in the world? And what is the most rare disease in the world? And I'm sure Dr. Rajat, because he has given me the, such an interesting topic, I think Rajat is the right person to answer this. So Rajat, before you Google, can you please tell me how do you define a rare disease? Rajat, come on, put on your camera. We all want to see you answering this.
So, sir, a rare disease is almost like a RET amplification in a metastatic small cell lung cancer.
Okay, that's nice one. Okay, second one, how many approximate incidence of people with rare disease in the world? Any idea? Just any idea? I'll show you the answers for this. Okay, Venkat is
incidence of patients living with rare diseases in the world. Very few, so less than 5, I think.
Come again? Okay, Vikas Talreja?
Less than 5%.
Less than 5%. Fantastic. Vikas is there. No, Vikas only photograph is there. And Venkat is there?
Sir.
Yeah. Hi, Venkat. So what is the, so you, for your caliber, what is the most rare disease in the world? Only you can answer this, definitely.
Common sense, sir.
Common sense. Fantastic, Rajat. Fantastic, Venkat. So I'll give you some answers of this. So according to the Rare Disease Act of 2002, and this is there from Wikipedia, okay, and this is not something which I'm making up. So Rajat, this was what took away the major time in yesterday night. In USA, it is less than 1 in 1,500 people. In Japan, it is 1 in 2,500 people. In European Commission, again, it's 1 in 2,000 people. In medical literature, it can come in 1 in 1,000 to 1 in 200,000 people. That was the definition of the rare diseases. How many people are affected by rare diseases? 30 million people in United States who are living with a rare disease. How many rare diseases are there? There are 7,000 known rare diseases. And the most rare disease is what you said, Venkat, was right, common sense. But ribose 5-phosphate isomerase deficiency is the rarest known genetic diseases. But Venkat, what you said right, common sense is the most rare disease which we have to see right now, which is being seen right now. So let me come back to track now. Dr. Bharat, do you think that the incidence of rare mutations that you're finding in your clinical practice has increased in the last some years?
Sir, to answer it, the incidence has not risen, but the way to diagnose it has risen. Correct. So probably we did not have the tools to diagnose it, because older thing we used to do a PCR. Now with the availability of broad-based NGS and particularly RNA also, I can add on it, because now we are able to diagnose this rarer mutation commonly. So if to answer it correctly, is the incidence increasing? No. But the pickup rate is increasing with the availability of better platform to pick these types of mutations.
Absolutely agree with you. Dr. Minesh, sir, you seem very serious. So I'll ask this nice question to you. I mean, sir, you are muted, sir.
Yeah, okay.
So in your practice, sir, what is the incidence of rare mutations? And you have been practicing for a long time. So do you think the incidence is increasing, or as Bharat very rightly said, is it that we are recognizing it more now?
See, the incidence of cancer is increasing, 21% increase in cancer in last 10 years and 26% mortality in last 10 years worldwide. So there is an increase in incidence of cancer. So obviously, with new NGS, we are seeing more mutations. We never thought of exon 20. Now we have started seeing exon 20. When the drug comes, you start searching for it. See, when you don't have a drug, you don't search for it. So it's not that they are not present, but your lookout is there only when you have a drug for it.
Okay. So what Dr. Manish is absolutely right is, I mean, it's a very pharmaceutical driven talk also, which is right, sir. Because even if you have a drug for, let's say, CCND or something, PIK3 was always there. PIK3 is there in lung cancer all throughout. But since it is not targetable, nobody talks about that. You're absolutely right in that, actually. Rajat, what is your prevalence of, in your practice, what is your prevalence of rare mutations that you see in, let's say, in the last 1 year or 2 years, out of all 100, 200 lung cancers that you see?
So, sir, I have seen, maybe I can peg it at 1 to 2%, not more than that.
Okay, 1 to 2%. Fantastic. Venkat, are you there? Dr. Venkat?
Yes, sir, I am here, sir.
So, Venkat, from Rajiv Gandhi to Hyderabad, to Visakhapatnam to Assam now, has the incidence increased, decreased, static?
Sir, lung cancer is quite common here, sir. And majority of them they present in quite an advanced stage because of no oncology facility in the entire state. So coming to the rare mutations, sir, definitely yes. I have seen only 3 cases in my last 2 years, sir.
Okay. Is that because you are not doing NGS enough, Venkat? And that is why everybody, Bharat in Hyderabad is doing, NGS almost for everyone. And maybe because, is that the reason?
Yes, sir, because NGS is a high throughput investigation, so gives more information and obviously more amount of rare mutations also.
Okay. Let me start with Dr. Manish now. Dr. Manish, sir, how will you classify exon 20 insertion as common, uncommon, rare?
See, basically exon 20 right now I'm doing a study. So for me, it is common because I keep looking out for it. And it is uncommon. Basically, it is, you can say 1% of all the mutations, 10% of all EGFR mutations are exon 20.
Okay. Dr. Bharat?
Not rare, it is uncommon, I say. That per we see quite a few now, sir. Actually, again, the thing is, our pickup rate has again increased. So exon 20, yes. We have seen, last 6 months, we have seen 3. In fact, I have talked to you also for sending patients, sir. So yes, sir, we have started now. Probably Again, the pickup rate has increased, but yes, it is uncommon, but not rare.
I think again the fact over here is both the medical oncologists and the molecular pathologists are actually, what Dr. Manish said was absolutely right. We have started looking. You know, I still remember in 2011 or 2012 when the report used to come, it was EGFR present or absent. That's it. It didn't make a difference whether it was DEL19 or it was exon 18 or co-mutation or no. So now, because we now are probably trying to personalizing the more personalized treatment, that is why we are looking for it. And definitely we know and we have got drugs available. Absolutely right. I mean, point right on the head over there. So let me start with exon 20 insertion. So let's say I will go to Dr. Venkat first, and then Dr. Bharat, and then Dr. Manish, since you have a trial. We will go to you now then. Venkat, let's say you have a patient with stage 4 non-small cell lung cancer, EGFR exon 20 insertion. What would be your choice of treatment in Assam today? How would you treat? And I'll talk to Dr. Bharat and then Rajat after that, and then Dr. Manish.
Yes, sir. So in my facility, I would go for chemotherapy, sir, with exon 20 mutation.
You will go for the standard chemotherapy with pemetrexed carboplatin.
Yes, sir.
Let us say the
because
guy
I do not have access to even NGS, so I cannot.
So fair enough. Let us say the guy has a lot of money. Let's talk about that. Will you give chemoimmunotherapy?
So upfront in a driver mutation, in a driver addicted tumor, no, sir, no.
Okay, fair enough. Dr. Bharat?
Sir, agree, sir. I will not give immunotherapy. The first thing I do is practically I try to send my patient to one of the centers who is running this trial of carbotaxol with if it is not feasible, then I go ahead and give a chemotherapy to my patient. So, regarding immuno, no, sir. I am not giving immuno in any of my drivers.
What about afatinib?
Not exactly, sir. If you say the data for exon 20, afatinib is also not so good, sir. If anything, probably chemo will be as good as afatinib. Maybe some data was there for twice the dose of osimertinib.
I will show you the I will show you the data, because you know, I mean, I do get a call very frequently from my friends all over. Exon 20 hai, should we give osimertinib or afatinib or this? So you know, a lot of people are in doubt on that. Rajat, what would you do?
So, sir, I would like to start this patient on platinum-based therapy, telling them very well that the PFS is not going to be great, and then explore other options like a clinical trial or amivantamab, also if that is available.
So, okay, fine, fair enough. So, let us just talk about the exon 20 insertions. Rajat, to you only. Are all the exon 20 insertions created equal, or there are differences in the exon 20 insertion also?
There could be, sir. I am not sure.
Lot of differences.
So there are a lot of differences, Rajat. I was, you know, I mean, that is why, since we also have the trial, if you do NGS, there are certain insertions which are sensitive to amivantamab. There are certain ones which are sensitive to mobocertinib. There are very few which are sensitive to afatinib or osimertinib. So some mutations are there with that. So even with exon 20 insertions, you need to talk to your pathologist, need to look at the mobocertinib and the amivantamab data about which one is actually available over here. Dr. Manish, sir, what is your take on amivantamab or mobocertinib or poziotinib? You know, a lot of time in our WhatsApp, the WhatsApp Gyan on the medical oncologist group, people ask over their exon 20 insertion, this drug is available, what to do? Your take, sir.
See, right now there are two drugs which are approved, amivantamab and mobocertinib. There is no clear defined criteria which one should be used when. I have no experience on mobocertinib. I have used amivantamab and I find the drug quite interesting.
Okay, interesting is a very interesting word, sir. What is interesting about amivantamab?
Because it's too short for me to give an answer that it is working great. Okay. But it is definitely working. What we can see on face of a patient once we start a drug, and a targeted drug makes change in their way they are happy within 8 days, 10 days. You see a different kind of expression on their face. Okay. So that you start seeing with this drug quite quick.
Okay.
So that indicates that the drug is working. You also start getting the rash. You also start, but the only problem with this drug is that you need to be very sure about the breathlessness which starts in. Amivantamab has a breathlessness which also can be misinterpreted for a progression of disease, which is a pneumonitis, which one needs to be very careful with, and steroids need to be started quickly. That's the only thing which is tricky. Yes, definitely we know that this is a bispecific monoclonal, and these are the drugs which are going to make differences. See, we are all going with, even we have seen this in breast cancer, that we are doing a dual blockade. So similarly, a bispecific, the escape mechanisms are getting blocked. So this is something very, very interesting. That's the reason I said interesting.
So interesting is absolutely interesting, sir. Are these available in India? Dr. Bharat, you shook your head.
Clinical trials, sir, we are as such
Clinical trials. Both amivantamab and mobocertinib are available as compassionate usage. I will tell you the clinical trial. Dr. Manish has, I have the clinical trial, but both of these are available as on compassionate access actually. So we should actually be looking out for them. These were, I mean, this is a presentation that I took, and Rajat, you know, I did burn my midnight oil yesterday, and today was just to fool you in the morning. So this is the mobocertinib data in the EGFR exon 20 insertion, and this is what I took from ASCO 2021. This is second line trial, a median overall response rate of 25 to 28%, a PFS of 7.3 months, a duration of response of 17.5, and a median OS of 24 months. Almost equal to the TMH data, I hope Kumar is not listening, of pemetrexed and carboplatin plus gefitinib. So, and this is the second line setting. This was again, so this is a very important slide. You know, Dr. Bharat, you told us about the osimertinib data. Osimertinib data basically was there. What we need to remember is there are 4 options available right now in second line. First line, there is no option. First line, you give chemotherapy or it's a clinical trial. In second line, you have 4 options, at least right now. You have either mobocertinib, you have amivantamab, you have osimertinib, ATBD, or you have poziotinib. By and large, the main difference is the PFS, the OS, and the toxicity profile. The toxicity profile with mobocertinib is almost similar to what you get with dacomatinib or afatinib. 93% of diarrhea, 45% rash, 39% paronychia. Dose reduction was seen in 20% of people. So the toxicity is different. Amivantamab, the toxicity, which Dr. Manish didn't really say, was an infusion reaction. So ideally, you know, when we give the drug, when we have the clinical trial, we give the first dose in the ICU actually, because we are very careful about the first infusion reaction. But then 86% of people will get the rash, 42% paronychia. Osimertinib, a lot of people ask me about ATMGBD, not really convinced, and I'll tell you why I'm not convinced. Again, the 76% diarrhea, fatigue, thrombocytopenia, you rather give chemotherapy to these people, very rightly said. Poziotinib came in a very big way, but again, if you see the efficacy of that, not really acting. Now let's come to the duration of response of that, or a PFS, 8.3 with amivantamab, second line. I'm not talking about the first line. Median PFS of 7.3 with mobocertinib. Osimertinib, somebody will say the PFS is high, but only 21 patients were taken. So osimertinib, don't. Anyway, you will not even get PAP for that, because Astra will not give you PAP if you have a exon 20 insertion. And even with poziotinib, the things are, you know, 4.2, 7.4, nothing. So my take on this probably is, if you have a clinical trial, I mean, so this is what the finally said, you can either start with platinum-based chemotherapy. Please do not give immunotherapy. Why you don't give immunotherapy is because, you know, why you don't give immunotherapy is because you need to give the drug in the drugs which cause pneumonitis, and followed by either give amivantamab or mobocertinib over there. This is the trial that everybody is talking about, and this trial is actually available at Pune. This is available at us. Exon 20 insertions. First line we are comparing amivantamab and carbopem versus we are comparing pem carbo followed by amivantamab at progression. So if you come into the trial, you will definitely get amivantamab. Whether in first line or in second line, we don't know. We already have 2 patients, but we are looking for more. So Rajat, now you know where to send your exon 20 insertions as soon as you get those actually.
I have one, sir, but that patient has got a concomitant BRAF mutation also.
So then that guy will not
Exclusion.
really, he will not really be eligible, Rajat. But we have, this is just to tell that, there are trials available. Normally what happens is usually people say, we don't have a trial, and then, get out of that. Trial is available basically. Right. So this is the Papillon study. So this was about the exon 20 insertion, and both mobocertinib and amivantamab are available as compassionate usage. Amivantamab will also be available as on, they are getting the drug approved for marketing by August, September. Janssen & Janssen is the drug which comes over here. Now let's turn our attention to the part 2, that is the HER2 mutation. So you have a 72-year-old female, non-smoker. She has come back with massive pleural effusion. Thoracoscopic biopsies shows adenocarcinoma. Your PDL1 is 70%. Her EGFR AL cross is negative. NGS done. It shows a HER2 new mutation. So, Bharat, you were smiling on this. So since you were smiling on this, what will you do?
Sir, in an ideal scenario, it is not what I do. Ideally, the best drug with the data is trastuzumab deruxtecan, which we don't have it. So what I do is I give chemo with trastuzumab. What I do, Exanes with trastuzumab.
So you will start with the chemotherapy trastuzumab, the number 4 option. Fantastic. Venkat?
So seeing this case, I still very vividly remember the case of orbital metastasis with HER2 amplification in our unit when I was posted in your unit in 2016.
We were working together, Venkat. You were not posted. We all worked together. In fact, I worked with you guys. Tell me.
In 2016, so we tried to give TDM1. So still, TDM1 is better drug than trastuzumab. So if I have no constraints, I will go ahead with TDM1. Because in all the trials, we have seen in various cancers, the TDM1 fared better than trastuzumab. So in the first shot, I'll go for TDM1. Not much of data, but definitely yes. If
okay, so Bharat will go for chemo trastuzumab. Venkat will go with TDM1. Dr. Minish?
I tried TDM1 in one patient, didn't work much. So I'm not sure because I have only one patient's experience and chemotherapy is my choice. I would reserve targeted therapies for HER2 maybe at a second line. The cost is too much.
Cost is too much. Fantastic, sir. No issues. Vikas has joined. Vikas, you have, I think, probably given chemotherapy to all the patients in the UP now, and that is how you're coming. So, Vikas, what would you do?
I also agree with Dr. Bharat. Would offer chemo plus trastuzumab for the patient. It is something which is.
So why not? Can I put some more oil into the fire? Why not give pertuzumab also? So
but most of the data it is in HER2 amplification, sir. But here we are talking about mutation.
We will show you some data. We will show you some data, Venkat. I've learned from you guys. We will show you some data. Rajat, what would you do?
Yes, so between chemo plus trastuzumab and TDM1, there is
first
data
line.
to suggest that there is
So
response.
is there a data of TDM1 in first line, Rajat?
Sir, there is retrospective data of TDM1 in first line with response rates of about 40%, and this is more than what it is with chemotherapy plus trastuzumab. So if I have to choose one, I'll choose TDM1.
Okay. So this is some data that I was wanting to show. This is from ASCO 2021 once again. This was a data, Venkat, of trastuzumab, pertuzumab, and docetaxel in patients of non-small cell lung cancer with HER2/neu2 mutation. And this is what they basically got. And finally, there was a median PFS of only 6.8 months and a median overall survival of only 17.6 months. That is the data of PTH. And this is what was the one which was with TDM1. And this is the one which is there with trastuzumab deruxtecan, which everybody has said. So if you have a TDM1, the overall response rate is 50%, median PFS is 5 months. But if you have a trastuzumab deruxtecan drug, that is 14 months of median PFS, a wonderful waterfall plot curve, and a median OS is not really reached. So probably the way to go forward, what I do is we give chemotherapy to start with. Initially was very tempted to, when Venkat was there with us, very tempted to add trastuzumab, not so anymore. Start only with chemotherapy. On progression, I do give them TDM1, ask them to get TDXG if it is possible for them. That's what I do. What we also do over here right now is, though this data is something to check it out, And so this is what the NCCN guidelines actually says, that if you have a HER2 neu mutation, you should give TDX or a TDM1. What we are basically doing is we are now recruiting again Rajat and Vikas and Venkat and Bharat and everybody else. We have a first line trial of HER2 neu mutant NSCLC, in which we are comparing trastuzumab deruxtecan versus pembro-pem carbo. For that, the patient has to be the first line. Patient should not have received any chemotherapy before. Eagerly awaiting this trial. We have just starting this trial. No patients enrolled till now. But trust me, trastuzumab deruxtecan, because we have trials in breast as well as in lung, the drug is fantastic. There is a drug-induced pneumonitis, but it's worth, with breast cancer, at least the fungating lesions have all disappeared, and the drug is fantastic. The whatever little experience we had, it's a fantastic drug. But now we are getting in lung also, so hopefully we'll find out how does it really go from here. Moving on to the third one, the KRAS ones now. So now this is again a real life scenario. A 65-year-old female, never smoker, diagnosed as stage 4 non-small cell lung cancer with massive pleural effusion. Again, EGFR IL cross negative, PDL1 25%. Started on pemetrexed carboplatin. NGS showed KRAS 12C after 2 cycles have been given. So Dr. Minish, a real life scenario. This patient was being treated by, again, one of the people that I have worked with. 1 cycle PEMCAP, that is what I do. 2nd cycle PEMCAP. Now the NGS report has come as KRAS 12C. Will you continue chemotherapy? Will you combine pembrolizumab? Will you give sotorasib? Or what will you do something else?
See, basically, sotorasib is costing 20 lakhs.
Sir.
So if you have a possibility, you can go for generic Bangladeshi drug, costing 85,000.
I didn't know that was there, sir.
I don't know.
Okay.
I have not used it, but I've got the information that it is available. And the thing is that though this KRAS mutation, we don't consider, it is almost 10 to 12%, which is quite significant compared to all ALK and other things.
Yes, sir.
So KRAS, basically, I prefer using taxanes compared to pemetrexed. The drug works better with KRAS if you have no choice of using sotorasib. Sotorasib also is like, I have not used it. It's quite significant cost and toxicity, which is.
So my question here was sotorasib. I knew, sir, everybody will say that, we will not use because that drug is not available. Will you add immunotherapy? That is what I want to ask.
No.
You will not ask immunotherapy. Okay. Dr. Bharat?
If you tell the best data of immunotherapy in driver mutation, is it with RAS mutation only?
Yep.
So probably there is a point to say that probably I may add on. Again, nobody has the correct answer to this, but if one subset of a driver mutation where I may think of using a immuno, because 57% if you see, that could be this RAS mutation. Now, what I will do in this case, I'll continue with chemo or chemo immuno, and then because the data code break 100, the data is not probably in the first line as far as my knowledge. So I can add on this drug whenever it is available, but I'll not stop chemotherapy. I may continue my chemo.
What you said, Dr. Bharat, was absolutely right. If there is a data of single agent immunotherapy, that is in 3 driver mutations. The best data. One is the KRAS, second is the BRAF, and third is the MET.
Yes.
So if you have these 3 mutations, the same response rate of around 20 to 23% are there, and the remaining it is absolutely not there. Venkat, your take?
So, just like Dr. Vaswani said, because it makes sense that most of the patients who are smokers, they have KRAS mutation and also more tumor mutation burden, where we expect immunotherapy to work. So they are the common group of cohort of patients which have a. So yes,
fair enough, can give. I mean, I agree with both of you. This is one subset in which you may actually give patients immunotherapy. Vikas or Rajat, anybody is there?
Yes, sir, I'm there.
Yeah, Rajat, so your take.
So if the patient is responding well, then I may continue with only chemotherapy. If the patient, because it is written that only 2 cycles have been given, and if the patient is like kind of stable, then immunotherapy can be added in this subset, because as everybody said that KRAS is there and we can add immunotherapy to chemotherapy.
That is what exactly I have done. I have actually added the pembrolizumab in the second or third and the third cycle. Unfortunately, the lady is right now admitted with the febrile neutropenia. She's ascribing everything to immunotherapy, but that's okay. So this was Dr. Bharat was what you told, and sotorasib was given in the second line. Data, and the PFS basically was 6.8 months, and the duration of response was around 8.2 months. But that is what I didn't was something which we all know. One thing very important which I wanted to discuss and bring out, and I'm sure we are going to bring out, because as Novartis brings out and rolls out more and more data about KRAS sotorasib, a role of co-mutations is going to come up in a bit more in a huge way. So when I first thought about co-mutations in KRAS mutated non-small cell lung cancer, my reactions actually were like, this is like jigri yar status. Man is known by the company it keeps. KRAS, you should always be bothered not only about KRAS. It's not about the, first of all, it's all about the KRAS. The sotorasib works only in KRAS 12C, but we should always be looking out for the co-mutations also. I will just show you certain data. And this is the data which is very important. Unfortunately, in the coupon scan that is being done by most of us, STK and KEAP mutation is not being done. In patients with KRAS mutant non-small cell lung cancer, always ask for the data of STK and KEAP mutation, because if you have the best data was basically seen, if you have a STK, so if you have a KRAS mutant, and you have a STK11 mutant, and you have a wild type KEAP, that's the best thing to do with the KRAS. But if you have a patient who has KEAP mutation, these people will not respond basically to sotorasib also. That's a very, very, very aggressive disease. So I'm sure this is the thing for the future. And probably next year when we will discuss more and more about KRAS, because sotorasib is going to get available in India probably in another 1 year or something, we will be starting to look at the role of co-mutations in non-small cell lung cancer in the and co-mutations with STK and KEAP are going to come up in a huge way. For right now, if you have a KEAP1 mutation, tell your patient your chances of responding to any therapy, any drug is practically very, very less. Always have a look at the co-mutations also. Any thoughts on this, Dr. Minish, sir?
No, I agree that co-mutations are important, especially for this particular subtype.
And we need to, we need our NGS people to tell, because, while we were designing the panel for our own hospital, we have in a lab, and I told them we should keep STK, keep. We had a huge discussion with the pathologist, but finally I told them, showed them the data, and we could prevail over them actually. So very important for all of us, because the commercial labs that are doing may not be doing STK key. Venkat or Vikas, anybody who wants to comment?
So definitely this is what makes a medical oncologist giving a therapy for advanced cancer makes stand out compared to other oncologists, because having this mutation, give that target therapy, seeing NCCN guidelines will not make much of difference. But here comes the role of medical oncologist, and I completely agree with you.
You are taking this discussion somewhere else, and I'm not biting the bait. I'm not going over there.
No, sir. So definitely, because it is our medical domain to understand this genetic biology, because from the very early trials of Jefnib, where we have given to all the lung cancers, and initially said that actually Jefnib may not work, but retrospectively we found that EGFR. So these help in better selection of patients to the targeted therapies, and definitely the response rate will increase from this 10-20% to 60-80%, and one time it may replace the chemotherapy.
That's the dream. Chemotherapy should be a thing of past in lung cancer at least. Vikas, you're smiling.
I totally agree, because pembrolizumab fails miserably in STK11 and the KEAP, and this is the subset where sotorasib you can import. I've tried the Bangladeshi one, and it has so far succeeded so far now, but touchwood again saying that it's not to be said on a public platform right now.
Okay.
Especially some sponsored session right now.
This is not a sponsored session.
I
I don't want to come into any sponsored sessions. And when I come to a sponsored session, I actually say things against them. That's why they don't call me. So this is where a man is known by the company it keeps. And before you go and looking for more Bangladeshi subgroups, actually, we have another trial for KRAS also coming up. So Rajat, thank you for this opportunity to showcase the trials that we have. So
people must be thinking that there is a plot between the two of them.
So this is another trial. This is a trial which I'm looking forward to. That's a trial in which they are comparing KRAS versus the sotorasib versus docetaxel. The catch over here is patients must have received immunotherapy and chemotherapy prior to that. So whether you give a keynote 189 or you get a checkmate 1757, patient should have got an immunotherapy and chemotherapy prior, and then only we will randomize them between sotorasib and docetaxel. So this trial we are enrolling. This is not yet enrolling. We are enrolling this. We are going to put this trial probably in 3 to 4 months time. This trial should start recruiting patients actually over there. I think we are. Rajat, shall we end or one more case?
One more case.
One more case. Fantastic. So what about Jab We Met? That is a MET rearrangement, in non-small cell lung cancer. My first reaction whenever I talk about MET is basically Jab We Met. But Karina has met someone else and Shahid has met someone else, and we are the only one who are not meeting anyone right now. So very important again, MET aberrations in lung cancer, very, very important. People actually say MET. So when you look at the MET, you look at three things. One, you look at the MET fusion or amplification. One, you look at the exon 14 skipping mutation. And one, you look at some other SNVs. Right now, what we need to remember in the interest of time is the drug is approved only for exon 14 skipping mutations. It is not approved for MET amplification. The problem with MET amplification is that, there is no right cutoff value. Different labs, some people say 6, some people say 8, some people say 10. The drug may work as a number 2, number 3, but right now the only proved indication of capmatinib which is available is exon 14 skipping mutation. That is one thing very, very important. Now, how do you test for that? Dr. Bharat, how will you test for MET exon 14 splicing?
The best way is to do a RNA NGS. That is a gold standard rather than a DNA NGS, because pickup rate is better with RNA NGS. So because we are doing a RNA NGS, so we have picked up 2 patients in the last 6 months.
Yeah, very right. So the ideal one probably is if you do a liquid biopsy or you do a tissue biopsy NGS PCR, MET amplification, NGS or FISH, the exact values have not yet been determined. What we basically know is please don't do IHC. So NGS is the way to go. DNA, RNA based is much more better. Definitely liquid biopsy can take over there, but please don't do an IHC and then say, we want to treat. If you treat MET on the basis of an IHC report, please have your professional indemnity ready and raised by another 20-30 lakh rupees. So some unanswered question, MET exon 14 splicing mutation, how will you treat? So let's say you have given 2 cycles of pemetrexed carboplatin, and you get the same report which we got in HER2 or a KRAS. Will you give first line capmatinib or second line capmatinib, or will you add immunotherapy or not? Anyone can take. Rajat, you can take.
So, sir, if we talk about immunotherapy in MET exon 14 splicing mutation, immunotherapy can be added to chemotherapy. But if I am to choose, then I'll be adding the capmatinib to this patient. I'll be giving capmatinib to this patient.
Venkat?
So it's a splicing mutation. I am not sure about capmatinib, but chemo plus immuno in the first line. And
okay. So we are split between Rajat and Venkat. Fantastic. Dr. Bharat.
Capmatinib all the way. So the best data of capmatinib is in the first line, if you see.
2-1.
I'll be no 2 thoughts. We have started with 2 patients.
Okay, Vikas?
Agree, capmatinib, exon 14 skip mutation.
Dr. Minesh, you are the final word.
You can use capmatinib or tepotinib.
So you will basically use capmatinib, the TKI agent, and this is what I just wanted to show basically over here. And I will just give my final comments. Basically, the outcome, a single agent outcome of immunotherapy is by and large a response rate of 20%, PFS of 1.9 to 3.4 months. And if you compare, and that's very, very important, you know, the best data of capmatinib actually is in the first line. So we had a patient like this, we gave 2 cycles of PEMCAB. The patient was deriving benefit. We stopped the chemotherapy, gave capmatinib after that. And then when the patient has progressed, then we have given the patient immunotherapy. Again, probably my feeling over here is that all the agents all the TKIs basically should be given to the patient in the earlier stage of the disease. Patient may default, patient may not be fit enough in the second, third lines. Immunotherapy is not a selective treatment. If you have a target therapy available, we should give it in the first line basically. So I think that is the last one that I had, and I will end now. I had 2 more very interesting cases, but we will start over here. I think with increasing uses of NGS, rare mutations will be picked up more frequently. Bharat was absolutely right that, you know, it's not the incidence is not increasing. We are getting it more. Smoking, age, gender is not predictive. You can get it in a non-smoker, you can get it in a smoker. There are target agents available for approximately 10 oncogene addicted NSCLC. Immunotherapy decision should ideally be deferred till the time NGS report is available. There are clinical trials and compassionate use of drugs available. The survival of stage 4 non-small cell lung cancer continues to improve. So rare definitely is special, and rare is many, rare is strong, and rare is proud. And thank you, Rajat. Thank you for giving me an opportunity to moderate. And thank you because I learned, I read. Thank you.
Excellent, Ullas. Absolute excellent discussion. Wonderful. You are the best.
Yeah, Ullas, it was great.
Thank you, sir.
So it is only because of people like Venkat and Rajat that I have worked with, that, you know, they are the one who inspire me to do something better.
So,
no words, sir.
So thank you so much, sir. It is very rare that you don't end with sarcasm, and that is what the rare.
You didn't get the joke, Rajat. I did end with sarcasm.
I told you to continue because like Dhoni is batting right now for CSK, you also are the Dhoni of medical oncology. Thank you so much once again for making it as interesting as possible always, and making us learn always. I thank all my panelists for being there till 9 p.m. So now with this we come to the end of this 2-day session on the oncology update series. The day 1 was for GI and day 2 was for the lung. We all learned a lot, and we, as an organizing team between me, Dr. Chaturbuj and Dr. Venkat, we all thank you for being a part of this meeting. And I hope that we've shared good content and an academic discussion between all of us to really tell us as to how we should go about improving our treatment strategies in times to come in both GI and lung. So with this, I thank you all once again. I thank the team of Mr. Mathur at Horizons for helping us out managing this event. And of course, I thank all the pharma companies for giving their generous grants. Thank you once again, and wish you a great evening ahead. Thank you.
Thank you. So Ullas sir, it's like a triple R Rajamouli ending. Thank you so much. It's absolute pleasure listening to you always and anytime, anytime, number of times. Thank you.
Thank you guys. And I was actually being honest. You guys are the ones that keeps me going. Thank you.
Thank you, sir.